All right. First thing I'd like to do, I'm going to show you a little bit of a video. Would you possibly turn off all the lights in the room you possibly can? I know these can't go off. Turn off all the lights for just a moment. Okay, I need the room to be a little bit dark in order for us to show these videos.
You doing all right?
It's a little hot in here.
A little hot?
Mm-hmm.
You mind checking the air conditioner? Seems a little hot in here. Check that. Go ahead and open.
You should open your mouth back up. Doctor?
Go ahead and open.
He's sitting down.
Charlie? Charlie? Let's go get some oxygen.
I don't think he's okay at all.
Charlie? 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 Where's the tubing? Go get, there's some tubing. Go get the tubing. Charlie?
Come on.
Charlie? Charlie? Come on.
Great. Can you hold it?
Pull that over his face.
Just water.
Do we have another tank?
That's the one we have.
Great, this is empty. Call for help. Call an ambulance. 911!
Okay, yes, Mr. Jones. We have you down for 3:15 on Wednesday, Wednesday the 16th, July 16th. Okay, thank you. Make sure you bring your insurance card for verification. Thank you. Okay, we'll see you then. Bye-bye.
The patient's not responding. You have to call an ambulance
What?
right away.
Oh my God. Hello?
Charlie. Just get him some oxygen here. I think we'll be at home. Charlie? Charlie? Come on, Charlie? Charlie?
Doc, do you have any information whatsoever on this gentleman? Any complaints?
Just doing a filling.
What kind of medications did you give him?
Just some
How long was it before when you became aware he was like this? Or when's the last time you actually talked to him?
about 70 minutes ago.
Okay, so he was talking to you at the 8-minute mark ago, is that correct?
Where we're just working on his teeth.
Was he talking? Was he responding, moving his eyes?
What he's done is he's talked to his medical director, and because of the length of time that he's been down with no response, the medical director has authorized him to stop.
Anybody know where family's at or anything?
Hey, Doc, I'd be happy to find you guys some CPR classes or something. If you ever interested in that, it's all out of the life for you.
Especially doing this in the medical exam.
Everything stays as it is.
Yeah, I'm just gonna wait around till he gets there.
Okay, that's our start for the afternoon, a nice upbeat beginning to the afternoon. Medical emergencies can and do happen in the practice of dentistry. I wrote a book on medical emergencies back in 1975, and that was the very first entry into the book. I've written lots of articles, and I've given probably thousands of lectures on medical emergencies, and I always start out the same way. These things happen. We had lunch together, several of us, and you know what? We were talking about complications in dentistry. The complication, perhaps, of when you give an inferior alveolar nerve block, getting the nerve, hitting the nerve with a needle. And you know what? It happens. Stuff happens. I mean, if you think you're going to go through a dental career of 20 or 25 years and nothing's going to go wrong, you're kidding yourself. Things happen. And if the worst that ever happens to you is you damage a nerve and the patient has some permanent damage, you've been lucky. You've been very lucky. I mean, stuff goes wrong. You try the best you can. You're getting a great education. Stuff happens. And think about it. If a patient gets lingual nerve damage, they're still alive. I mean, there's an awful lot of stuff that can go on that's worse than lingual nerve damage. And this is one good example of it right here. Medical emergencies happen. So what I want to do now, what I'm doing now is 3 hours, 2.5 hours, 3 hours on what I normally do over 8 hours. So I'm actually going to give you sort of a mini version, if you will, of that. What's happening? When does it happen? And what is causing it to happen? Let's go through some of these things. Preparing your dental office. Now, here's the thing that's going to be a problem because we're in Guatemala. We have people here from El Salvador. You know, I'm talking about my country. And the legalities are different. What a dentist is permitted to do in the United States may be different than what you're allowed to do here. You don't have 911. So you have sort of. You have a private ambulance service that you sign up with. Right, exactly. But you don't have the national number. You as a dentist, we'll get to that later on, but yeah, there is sort of. It's sort of. So there are things that are different. But I'm going to make the assumption that here we are, we're back in the United States, because the only way I can think is how we do it in my country. So again, some of this may not be applicable to what we're doing here. What is happening? Well, what is happening? I didn't show you this morning. This is that survey where I said to you 75% of all medical emergencies are stress-related. In the early 1900s, oh God. In the early 1990s, see now nobody laughs because they really believe that I could have done this in the early 1900s. I am not that old, okay? In the early 1990s, I did a survey. I give perhaps one postgraduate course like this a week somewhere in North America, about 50 a year. Local anesthesia, medical emergencies, sedation, things like that. And I gave a questionnaire out to the doctors when they came in. And the questionnaire dealt with your experience in your practice with emergencies. Very simple question. In your dental practice, regardless of how many years you've been in practice, has there ever been a medical emergency? Now, I had 4,300 doctors in the survey, 4,300 dentists from every one of the 50 states in America and 6 provinces in Canada. 95% of the doctors said yes. Yes, that at some time during my career, on at least one occasion, something has happened in my dental office which was a medical emergency. 95%. Then I gave them a list of 18 things, 18 different things, emergencies. And I said to them, doctor, for example, in your practice, has anybody ever had a seizure, convulsion, seizure? And if the answer was yes, 1, 2, 3, 4, 5, how many? So 4,300 doctors in the survey responded with a total of over 30,000 medical emergencies. 4,000 doctors, 30,000 emergencies is a little more than 7 emergencies per doctor over their career. Most of the time, the victim was the patient. Some of the time, the victim was The doctor, the assistant, the hygienist, the receptionist. It could have been the parent who brought the pediatric patient in. In other words, everybody, anybody in this room, and the unfortunate thing, the experience this morning, right? People have problems. They die, they have problems. And these are not dental problems, these are medical problems. Medical problems happen anytime, any place, anywhere. Simple. So as a doctor, as a person who is allowed, who is licensed, is allowed to treat people, to inject drugs into them, to cut on their teeth, to cut on their tissues, you know what? We have an obligation to those patients, not just to do things in their mouth that are good, but if something should happen, we hope not, right? But if something should happen, I believe, and in America it's your legal responsibility to be able to take care of it. If something happens to your patient in that dental office, our obligation as doctors is to be able to manage the problem. So let's discuss this. 95% of all the emergencies were on the left-hand side of the screen. These are the things that we see. Syncope is fainting. Allergy, not the life-threatening anaphylaxis. No. The typical itching. Mild, non-life-threatening allergy. Angina. Chest pain. Third most common. Postural hypotension. A drop in blood pressure when the patient stands up. It happens to people in this room. It happens to everybody, doesn't it, on occasion? You're sitting down or you're lying down for a long time and you sit up rapidly. You got dizzy. That's postural hypotension. Now, if that happens in your dental office and the patient falls on the ground and gets injured, in the United States, the doctor is liable for that injury. Now, it most often happens when the treatment is over and the patient stands up, falls over. And the reason it happens, of course, is after the treatment is over, the doctor walks out of the room, the patient's in the chair, the patient stands up, and they collapse. Okay? Postural hypertension. Seizures, asthmatic attacks, hyperventilation, the so-called adrenaline reaction, epinephrine reaction. And the number 9 most common emergency is low blood sugar, hypoglycemia. Those 9 on the left-hand side of the screen will be 95% of all the problems that we're going to see in dentistry. The other 9 on the right-hand side of the screen are only 5%. And be thankful, because the ones on the right-hand side of the screen are serious. Cardiac arrest, anaphylaxis, myocardial infarction, the heart attack. Be thankful they don't happen very often. They can happen, they do happen, but they're rare. The ones on the left-hand side of the screen are the most common, and the only thing I can say about them, we'll discuss a couple of them this afternoon. The best thing about those 9 on the left-hand side of the screen is they're easy to treat. They're easy to treat. You know, you shouldn't hear about a patient who died in the dental office because of angina or fainting or a seizure or an attack of coughing. Are you okay? Okay, good. Okay. They're easy to treat. They're easy to treat. If you don't panic, if you do the right stuff. I'm getting nervous now. Now, I showed you this morning. When does it happen? Remember, it can happen anytime. But the most likely times for emergencies to happen in a dental office are when the stress level is highest. When a patient is scared, when they're sitting in the chair grabbing onto the armrest. We call this the white knuckle syndrome. You see this, white knuckle syndrome. 55% of all the emergencies occurred during the injection or immediately after the injection of local. 23% occurred during the dental treatment. Those are the 2 times when emergencies are by far most likely to happen. Local anesthesia, again, because that patient is now... Here's something that I have to be careful about. When I come here to teach a course, to present material on anesthesia or on emergency medicine, I'm saying what I believe. And there's some times when you as students, for example, might be taught something that's a little bit different. You know, so here I come in, I'm an expert, and you've been taught to do something a certain way, and all of a sudden I come in and say it's wrong. I didn't say it's wrong. I'm saying this is the way you're supposed to do it. One thing you have to learn as a doctor, that there's no one right way to do anything. There are multiple. The thing about dental school is you tend to learn one way. That because you have to learn something, and you're going to learn it this way. Well, if you're from Guatemala and you're going to the dental school here, or you're from the public school, you're from El Salvador. El Salvador is the country, okay? You know, right? And San Salvador is the capital, correct? I got to get that right. You may be taught something different than the people are here. You're doing the same procedure, but your professor thinks this is the way to do it. And the professor here says, here's the way to do it. They're both right. As long as the end result, in my case this morning, as long as the end result is successful anesthesia and you haven't harmed the patient, whatever you're doing is right. And once you graduate, what you're going to see the first year out, that there are other ways. The person you go to work for is going to do things differently, and you're going to learn to do things differently. Keep that in mind, okay? So if you're still a student and I said that this is black and you said this is white, well, it is black and white. Depends on how you're looking at it, okay? We had a discussion about local anesthesia during lunch, obviously. Okay. So, when the problem happened during the dental treatment, the patient got the local, the patient survived the local, the dental procedure started. When it happened, the problem occurred. The emergency happened during dental treatment. The two things that were being done most often were the extraction of a tooth or access for endodontics. As I mentioned earlier this morning, the two procedures where getting profound pulpal anesthesia consistently are most difficult. Most of the time, mandibular molars. The patient, sudden unexpected pain, the body starts to release large amounts of epinephrine, norepinephrine, a sudden jolt to the cardiovascular system, and that's when problems happen. Patient may faint, patient may have a cardiac arrest, an epileptic may have a seizure, an asthmatic may have an asthmatic attack, a person with angina has chest pain, sudden unexpected pain. So this is what happens. Again, reason, stress. Whether it's fear-induced stress or pain stress, it is still stress. And that's how important local anesthesia is to you as a dentist. It's not just you can do good dentistry. Good pain control prevents medical emergencies, period. It's simple. Now, on this list, and unfortunately the coloring didn't come out too well, but syncope, angina, seizures, asthma, hyperventilation, and the epinephrine reaction. Those emergencies are preventable. Most of the time, preventable. And the reason is, in a dental environment, the most likely cause of fainting, angina, seizures, asthma is fear. An asthmatic who is scared, person with asthma who is scared, can faint. Anybody can faint. But in a stressful situation, the asthmatic is more likely to have an acute asthmatic attack. A patient with angina can faint. But in a stressful situation, they're more likely to have chest pain. A person with epilepsy can faint. They're more likely to have a seizure. The most common reason these things happen is fear or a lack of good pain control. And I showed you that this morning. If you add up all the numbers, 75% of all the emergencies on my list are produced by stress. And if it's produced by stress, and if you have good pain control, and if you recognize a patient's fear and treat the patient's fear, then you take away the emergencies. They're not going to happen. That's the most effective way of preventing medical emergencies. However, we can't prevent them all. Stuff happens. Stuff happens. I mean, it's kind of a casual way to say it. Stuff happens. People get sick. People pass away. People have problems. And it wasn't your fault. It just happened. If somebody were in this room this morning, I don't want to do that. A patient comes into a dental office in California. The patient's a little bit older, has a history of some significant cardiovascular and cardiorespiratory disease. They come into the office at 4 o'clock in the afternoon, and they're standing at the front desk, and they're sweating a lot. They're standing, sort of holding onto the front desk, and they're short of breath. The doctor comes out. "Oh, hi, Mrs. Jones. How you doing?" Not a good day today. "Well, what do you want to do?" He says, "You know what, Doc, if you don't mind, maybe we should cancel the appointment. I'll just reschedule it for next week." And they reschedule. Patient goes home, within an hour is dead. He's dead within an hour. Now, if that doctor had that patient in the dental chair at that time, they would have been just as dead. This person was going to die. They died at home. The problem is, in California, in America, if they die in my dental chair, somebody's going to say, it's your fault. They're just as dead, the same thing happened, but if it happens in my chair, obviously, Dr. Malamed, you did something that made this happen. This doctor was brilliant. This doctor was smart. This doctor said, you know what? I don't want to go there. Go home, feel better, come back another day. We'll do it. The hardest thing for a doctor, physician or dentist to do is know when not to treat. Okay? It's easy to treat. It's easy. They walk in that door, you put them in a chair, you go to work. Okay? This is a totally different subject entirely. It's called physical evaluation. Hell, you've got to know when not to treat somebody. Okay? Keep that in mind, because you have an almost 911. Almost 911 is not quite 911. And 911 doesn't work that well, so almost 911 can't work as well as almost, whatever, okay? So we'll talk about preparation. Now, remember, California, United States. Now, in California, think of this. We have 30,000 dentists in the state of California. 30,000. We have 100,000 lawyers. 30,000 dentists and 100,000 lawyers. We are outnumbered 3 to 1. The bad guys are looking for people to sue. Okay? They're after us. They want anything goes wrong, we're going to sue you. So, Hippocratic oath, the oath that a physician takes when they graduate from medical school. The very first thing is do no harm. Okay? Do no harm. Do right. Do the best you can. Don't do anything wrong. In a medical emergency, our job as doctors, we're doctors, our job as doctors, is to keep the person alive. That's it. That's all your obligation is. Keep the person alive until one of two things happen. One, they get better. That's the best one. That's the best end result. Keep them alive until they get better. Good example of that is the person who faints. Person who faints, positioned properly, 10 seconds, maybe 15 maximum, they're back. You did good. You kept them alive and you did the right stuff, and the victim is now the patient. They're better. Okay? That's one example. Until they get better. Or until somebody comes on the scene who is better trained than you are and takes over the management. You're going to call, in other words, you're going to call for help. Whoever that's going to be, you call for help. But that person who comes in and takes over from you has to be a person who is better qualified at handling a medical emergency than you are. And quite honestly, in America, that's 911. These are we call them paramedics. They're not physicians, they're paramedical, emergency medical technicians, EMTs. What I do for a living, I do anesthesia. Okay? I do anesthesia, I put people to sleep, I wake them up. And if you think about it, we're going to discuss basic life support. I do basic life support for a living. I maintain airways for a living. Basic life support is airway, breathing, circulation. I maintain airways, and I mentioned this morning I paralyze patients on purpose. I breathe for them. So I'm pretty good I'm not pretty good. I'm very good at doing CPR. I'm bragging, but that's what I do for a living. I maintain airways and I ventilate people. That's it. So I'm better than you are. So if you and I are together and a patient has a problem, you know what? It might be a good idea. Let Malamed do it. But you know what? The paramedics come in. I'm a dentist. I'm a dentist in private practice. I'm a darn good dentist. A problem happens. I call in 911. They come in. Hey, you know what? Patient's yours. Because that's what they do for a living. I do dentistry for a living. I'm talking like you. I'm a good dentist. I'm a great dentist. I am not an emergency medical doctor. You have to know your limitations. But you have this obligation. And the obligation to your patient, look, they're coming to you because they know you're the best there is. How do they know? Their next door neighbor said that you are the best. Why are you the best? Because you give good shots. Remember that from this morning. They come into you and say, I want you to be my doctor. You should feel good about that. You know what? The patient in the back of their mind also has this thought in mind because they trust their doctor. They trust him. You have to sit in a dental chair and allow a stranger to put a needle in your mouth and inject in drugs. They have to trust you. And they sit there and say, you know, if anything were to go wrong, I know that my doctor would know what to do. And the problem with that last statement is it's not true. Most of our doctors, whether they're medical or dental, because the medical profession is no better than us, don't know what to do. They do not know what to do. And in fact, actually they might. But like all those doctors this morning, the one who prayed, the one who cried, the one who you know what? They knew what to do. What they did was they panicked. Okay, and panicking is the worst thing you can do in that situation. Unfortunately, it happens. Basic life support. CPR, cardiopulmonary resuscitation. Okay, CPR is basic life support. If I have a top 10 list of things to prepare for a medical emergency, number 1, 2, 3, 4, 5, 6, and 7 are basic life support. That is how important basic life support is. Always, in every emergency situation, there is never an exception. You always do basic life support first. And that's why I'm not calling it CPR. How many, you've had CPR? Do your students get CPR? You know, in your mind, if I said to you, you do CPR on every emergency, you're saying you're crazy, Malamed, because CPR is doing this, right? No, it's not. No, it's not. CPR, basic life support, position, airway, breathing, circulation. That's what CPR is. You don't always do all of it. You do whatever is needed. For example, you do CPR on the person who faints. You do it. You position them, and you lift up the chin. And guess what? They recover. You've done whatever steps need to be done. The very first step in managing every medical emergency, without exception, is basic life support. Okay? Then we have an emergency response team. We'll talk about that briefly. It's access to emergency medical services. And then whatever legally you are allowed to have in your office, because as a doctor, things happen, you need to have certain drugs. And I'll discuss them briefly with you this afternoon. Basic life support, CPR, has only been around since 1960. It's only 46 years old. It's relatively new. In other words, saving a victim's life. If somebody's heart stops pumping blood, in 1959, you were dead because CPR didn't exist in 1959. Since the introduction of CPR, basic life support, victims of cardiac arrest have a chance of surviving. it's not a great chance of surviving, depending upon where you are. In some situations, 74% of the victims of cardiac arrest survive. 74%. You know what the realistic number is? 5%. Most countries where CPR is performed, in the United States, for example, nationwide, survival rate from, now it's called out-of-hospital cardiac arrest. In other words, a cardiac arrest that happens to a person who is not hospitalized. Out-of-hospital cardiac arrest. Whether it happens at home, in a dental office, in a restaurant, out of hospital. National, United States, national survival rate, meaning walking out of a hospital alive. 5%. You know what that means? 19 out of 20 die. The reality is very different, isn't it? Even if you do the best you can, we're down to 5%. Now, again, I mentioned earlier, in certain situations, as high as 74% survive. And we'll discuss exactly where you want to be when that happens. You want to be there? Good place to go. It's called Las Vegas, Nevada. And I'll show you some numbers later on. Basic life support, again, the most important thing. I don't have the way, I cannot tell you, I can't force you to do this. You know what, I'm 62, okay? And there are people in this room who are in their 50s and 40s and 70s, and with the diet you eat, where's my group? With this wonderful diet you eat, let's go to McDonald's again. You know what? You should be trained. This stuff happens. Think about something else. I get off on this. I'm emotional about this because it's important. You are, I've met a lot of you who said to me, you are in your family the first doctor. Right? Farmers, you know, your parents did this and that. You are the first doctor. They're proud of you. I'm the first doctor in my family. You know, you're Dr. Malamed. Your parents think it's the greatest thing in the world. You're home with your family. Now, this is, I mean, the worst possible scenario, your mother or your father collapse in front of you. You're a doctor. Don't you understand what the expectation is by them? Right? You are a doctor. You should be able to save dad, to save mom. And if you, as a doctor, physician, or dentist, sit there and go, or pray, or whatever the hell you're going to do, I have a problem with that. Right? I have a big problem with that. If there's anybody who should be able to keep a person alive, it's us. It's every person in this room. There's no excuse. There's no excuse at all for a healthcare professional to not be trained to keep a person alive. Period. Okay? Again, the guidelines have changed. 1960, every 7 years, the American Heart Association, which is a group of cardiologists, have gotten together and they've reviewed the literature. How can we make the 5% number 6%? How can 6 become 8, 8 become 10? And they changed the guidelines. And most recently, until now, the guidelines were changed back in the year 2000. And there was a major change in the definition of basic life support. You watch television, you see the doctor shows. Is ER here? My favorite show. I sit down, I take all my lecture notes for this course by watching ER. Dr. Carter, Dr. Bent, you know, take it down. You got to learn somewhere. That's the best way to do it. But in the year 2000, they added something very, very important. And it's perhaps the most important thing they've done in saving lives in many, 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 many years. And it's the reason Las Vegas is 74%. And it's something called defibrillation. When you watch ER, they take the paddles, right? The paddles. Shock. They shock everything on ER. They shock dead patients, live patients. They shock flies. If you don't get out of the way, they're going to shock you. But you know what? Basic life support, which used to be something that was real highfalutin. It was actually part of what was called Advanced Cardiovascular Life Support, ACLS, is now part of basic life support. And in America, as you'll see, in one state, Florida, every dental office, as of February 28th of this year, 2 months ago, legally, every dental office facility must have what's called an AED, an automated external defibrillator, in the office. Every dental office in that state has to have it. Hey, I think that's great. Well, first of all, Florida as well. You go to New Yorkers go to Florida to retire, which means to die. You know, it's good to have defibrillators there. That was a definition. Now, last December of 2005, the guidelines changed again. And I'm going to go over some of this with you. I have on my website all the new guidelines. If anybody here wants them, you can download them from my website. But the guidelines changed. And there's now again, I'm making a presumption that everybody here knows how to do CPR. And you know that until last December, when you did CPR on an adult victim, you did 15 chest compressions, and then you ventilated twice in 15 compressions and two ventilations. And it was different for children and it was different for infants. Well, now it's changed. Now for infants, for the child and adult, it's the same ratio of compressions to ventilations. It's 30 compressions followed by 2 ventilations. Now, I'm not going to go into the reasons behind this, but the reason is simple. More people live. The survival rate goes up. That's the bottom line right there. By doing more compressions, more people live. Bottom line. Those are the new guidelines, essentially, right there. So, number 1, 2, 3, 4, 5, 6, and 7 is basic life support. Number 8 is in your dental office. First of all, in your dental office, doctor, the candidate, the person who is most likely to have a serious medical emergency is the patient, the person in your office who is most likely to have a medical emergency is the oldest person and the person who's under the most stress. And I think in most dental offices, this person is the doctor. Is dentistry stressful? Hell yes. I mean, for Mrs. Jones, who hates coming to the dentist, it's 1 hour. 1 hour of terror. And you know what she does to you? She makes your life miserable. Everything you do, she has to spit out, she has to go to the bathroom 5 times. I mean, she moves during injections. She gags all the time. You know what? For her, it's 1 hour. How many of hers do you have? You've got 6 or 8 or 10 people every week, every day. Okay? You're getting older, a lot of stress. See, in my dental office, as I told you, I'm good at doing CPR. I'm great. You know my problem is? If I need it. That's the one thing I have not figured out. How do you self-administer CPR? If I have a cardiac arrest, you know, they talk about this out-of-body experience you have. People say they could see. Well, you could see the rescuers, but you can't yourself do it. I want to be certain that in my office, now I don't have an office, I work at a university, but at my university, honest, every person who works in that building, students, faculty, staff, the people who work the night shift, the cleaning people, you know what? We train them in CPR. You know why? Dr. Malamud comes into his office at 5 o'clock in the morning on Monday. There's nobody else there except for the weekend maintenance crew. And you know what? If I sit down at my desk and if I collapse, I want to be certain that that person out there can keep me alive. And if they're not there, well, 3 hours later, the first dental student comes in and sees Dr. Malamud. He must be sleeping in his desk. Hey, Malamud, wake up. Malamud. And 3 hours later, it's, boy, it's cold. All right? I want to know that the people, and think about that. You want to know that the people who work with you in your office, I can keep you alive. You know, it's only fair that you can keep me alive. Okay? So when I have this office team, I want to be certain that everybody in my office is trained in CPR. Now, there are other things we might want to consider. For example, you know, in CPR, we have shake and shout, head tilt, chin lift. We're going to do 2 ventilations and such. I like this little animation. I just got this. This is a brand new animation. I got it. He's not doing it right. He's bending his elbows. We could argue about his technique, but at least he's trying, okay? Now, the emergency team in the dental office, what are the things that we can have people do? Well, I don't know if you call 911 here, it's going to do anything. I don't think 911 is going to get you any help. But again, call for the emergency ambulance. Somebody can get the oxygen. Somebody can start, if needed, do CPR. Somebody, if it's not a cardiac arrest, maybe it's somebody who simply fainted. Maybe somebody who has low blood sugar. Somebody can record the patient's vital signs. Somebody can go and get the emergency drug kit. If you have to call, again, I use the term paramedics. Ambulance is coming. We passed this big multi-medical building. What was the building we passed on the way back, right? You know, what is it, 5 or 6 stories? 5 or 6 floors? And if you're going to call for help and you're on the 4th floor of that building, you want to have somebody from the office go down to the 1st floor of the building, the lobby, and you want the elevator waiting in the lobby, don't you? You don't want to have to sit there with an ambulance and wait for the elevator. So you want people to do these things, and you assign tasks to your staff in the office. The doctor is the one who is responsible. You delegate tasks. The assistant can do this, and the hygienist can do that. You know what? Ultimately, anything they do or do not do is your responsibility. If they screw up, it's your fault, because it's your staff. Okay? Keep that in mind. Next, basic life support, 1 through 7. Number 8 was the emergency team. Number 9 is getting help. I have no problem with that. I'm a good dentist. Keep that in mind. You are good dentists. What is happening to your patient is not a dental problem. And there's no shame in calling for help. There's problems when you don't call for help and you need it. You know, when do you call for help? I can't tell you when to call for help. How many of the doctors in this room have ever seen a patient faint? Let me raise your hands. Okay, now, the rest of you are liars, but that's besides the point, okay? But the ones who said yes, did you call an ambulance? Did you, when the patient fainted? No. Why? Because they got better, right? You positioned the patient and they got better. That's true for all of you. For virtually all of you said they had a patient faint. You position, the patient gets better. Now, here's the question. You take the patient and they appear to faint. You lay the patient down in a chair. Lift their chin, head tilt, chin lift. They're breathing. I can feel it. They're breathing. I check the pulse. They've got one. Okay, now look. They've got a pulse. They're breathing. They've been lying in this supine position for 5 or 10 or 15 seconds. Those of you who said you'd seen patients faint would agree that within 15 seconds they're getting better. Once you position properly, they begin to wake up. Now, here's the question then. The patient appears to faint in your chair, and you position them and you're doing this, and I've been doing this for at least 30 or 40 seconds already. How long will you, the doctor in your office, your staff, by the way, is going, Doctor, what's going on? Doctor, what are you going to do about it? Now, my hands are occupied. I'm holding the airway and everything. If I didn't have my hands busy, I'd be going, Doctor, what's going on? Blah, 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 blah. Doctor, what are you going to do? Blah, 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 blah. I don't know. That's when you call for help. Right? You call for help because I don't know what the hell. How long are you going to stand there with a person who is unconscious? They're not in cardiac arrest yet. What are you going to do? What are you going to do? You know it wasn't a faint because they'd be conscious by now. That's when you call. It's a feeling that happens in your gut. It's a knot in your gut. You understand? You start sweating. Get help. Get help. Whatever the number is, you hire, you have to sign up for it, right? You sign up for it, you have an ambulance service. Your legal obligation in America is, again, keep that person alive until they either recover or help arrives on the scene that is better trained than you are and then takes over their management. And if that ambulance can arrive in 5 minutes, and if they're better trained than I am, and I'm hoping if I'm paying money they're better trained than I am, once they walk in the office in 6 minutes, fellows, ladies, take over. Okay? That's what you want to do. When do you call? As I said, as soon as you think you need help. Never hesitate. Don't be afraid to call for help. Now, don't go the other way. Whenever a patient faints, call for help. I mean, that's crazy. You'll see it again. You will see, as a dentist, you will see fainting, especially if you're giving injections to patients who are seated upright. That's the most common scenario. Fainting occurs during injections when patients sit up. If you lay the patient down, they wake up. My argument is lay them down for the injection, then they can't faint. Then sit them up after so it works a little bit better. Again, who do you call? I don't know where I got that number from. What is 125? Is that the Red Cross? That was in the phone book here. That was in the first page of the yellow pages in the Guatemala City phone book. They had Red Cross, they had this and that, so I think that's the Red Cross. I don't know if that's worth anything, but I had to put a number in, okay? Forget 125. I think it's Pizza Hut. I'm not sure, but, you know. Now, the last part of the preparation is emergency drugs and equipment. Again, this gets into legalities. It gets into what you are allowed to do here, whether it is in El Salvador or Guatemala. I don't know what the legalities are. So what I'm presenting you here is what I recommend every dentist in America have. A dentist who has no advanced knowledge of emergency medicine, none, which is your typical dentist, who gives local, who does good dentistry, has taken basic life support every 2 years to maintain. See, in America, in 37 of the 50 states, to maintain your dental license, every 2 years your dental license is up for renewal. On your birthday, every 2 years. You have to show that you are currently certified in basic life support to get your license renewed. That's the only reason these doctors take these courses. They wouldn't do it on their own because I don't need this. It'll never happen. So we say, okay, if you want to practice dentistry, you got to take that course. Good, it works, okay? You need stuff. So here's a dentist who doesn't want anything. Let's be honest. Would you feel comfortable in a medical emergency administering drugs to somebody? The answer is going to be no. Most of us in this room would be very uncomfortable. Maybe oxygen, right? Everybody would, oh, oxygen is okay. And it is. But other drugs, you know what? I don't know. Okay, so my philosophy is, here's a dentist who wants nothing. I'll do basic life support. I don't want any drugs. Now, if you're telling me that I need to have drugs, legally I need to have drugs, then I want only those drugs which are really, really important. If it's not important, I don't want it. I want, if only one drug is needed, I'm not going to have two. So now we're going to go to the NFL. We're going to go to the National Football League, and the draft is coming up in a couple of weeks. Or maybe it's even next week. And we have the number 1 draft pick, the number 2 draft pick, down to number 7. Number 1 draft pick by the Texas, whatever the hell that name of that team is, Reggie Bush from USC. Okay? Number 2 draft pick, the New York Jets, Matt Leinart from USC. I hope number 100, Vince Jones from Texas. Vince Young from Texas. Because that son of a bitch beat us. I was sitting there at the Rose Bowl. We're winning by 16 points with 6 minutes left. It's over. We win. No, we didn't. That son of a... We have 11 men in the field. The last play of the damn game. I'm sorry, I get emotional with this too. 11 men on the field can't stop one person. I mean, we didn't deserve to win. If you can't stop one person with 11, you deserve to lose the damn game. My blood pressure right now is way up. All right, so let's go through the draft pick. Number 1 draft choice, epinephrine. Adrenaline, epinephrine, the number 1 draft pick. Absolutely, hands down, no doubt. If there's only one drug you want, it's adrenaline. Now, it's a drug that you never are going to use, hopefully. It is for the anaphylactic reaction, the life-threatening allergy which happily doesn't happen often. But you know what? If it does, patients who get adrenaline fastest live. Patients who don't get it die. Period. Black, white. No doubt. Adrenaline, the most important drug in emergency medicine. All right, number 2 draft pick, oxygen. O2, oxygen. Okay? We'll discuss the other ones. But that's the way you have to think about it. You have to. I only want drugs that are important. Epi is important, epinephrine is important, oxygen is important. There are other important drugs too, and we'll discuss them in just a moment. I call that the bare bones basic kit. Bare bones basic, even an orthodontist should have it. Do you have orthodontists in this country? Do they? Do you? Yes? You have them. They don't do dentistry. They don't do anything. They make money. Orthodontists don't do anything. They make a lot of money doing nothing. They don't even touch patients. The only people in dentistry who wear suits and ties to the office are orthodontists. Everybody else is wearing scrubs. We're wearing a mask. They don't even come near their patients. They look in the mouth and they say to the assistant, put a number 6 band on that tooth. I'm leaving. Where are you going? I'm going to the bank. It's nice. Why go to dental school? You should go to business school. Become an orthodontist. But even the that's called jealousy. I'm jealous. They don't do anything and make a lot of money. But I believe right now, look, when I began teaching in 1973, remember, I'm an anesthesiologist. I go into the operating theater almost every day, and what do? I load up syringes. What I do is I give drugs to put you to sleep, give you drugs to keep you to sleep, give you drugs to paralyze your muscles, give you drugs to wake. I do drugs. That's my life. I do drugs. I start IVs every day. And one of the problems is when you start teaching, I don't realize that you, not just you here, but you in America, you in England, most dentists don't start IVs. So if I were to say to you now, when a patient has a seizure, start an IV and administer intravenously an anticonvulsant, if I say that, just get up and walk out of this room because this lecture is worthless. But when I began teaching, I didn't understand that. It took me a couple of years to realize that. And my emergency kit back in 1973, me discussing this to the general dentist, was the following 15 drugs. Everybody in this room should have the following 15 drugs. And after a number of years of teaching, I realized you don't need these drugs. A lot of these drugs are worthless. You know, you do not need an anticonvulsant drug in the emergency kit. You know why? How many of us have seen seizures, convulsions, ever in any environment, at home, on the street, in the office, convulsions, epileptic fits, whatever you want to call it? Anybody? And you know, oh, look, a lot of hands go up. You know what? They stopped. Didn't they? They stopped. Nobody gave any drugs. They stopped. You don't need anticonvulsant drugs. Take it out of the kit. So the kit went from 15 in 1973. It went down to 4 drugs in the 1980s. But then I saw an advertisement on television on your morning news show this morning for cardioaspirina. Aspirina, whatever. Bayer's aspirin. Okay, it's a wonderful drug. Well, we now have aspirin in the emergency kit. You know, the kit changes as emergency medicine changes. I mean, is it a hard thing for a dentist to say to a patient who's having chest pain, here, chew this aspirin? That's not very difficult to do. So we have aspirin in the kit. This is the 7 drugs right here. Now, the question we're going to get into as we discuss this, and again, we're not discussing every possible emergency here today because of the time factor, but what drug to give? And there's a very, very simple philosophy behind this. Number 1, drugs are not necessary in the management of most medical emergencies. Number 2, the primary management of all medical emergencies is basic life support. When in doubt, don't give drugs. If you do not know what's going on, if there is any doubt in your mind about what to do not administer drugs. Now, for a moment, let's take oxygen out of that picture, because oxygen is good. People die from not getting oxygen. Never. With oxygen, always. There is no medical, now listen carefully, there is no medical contraindication to the administration of oxygen to a person during a medical emergency. You see, there are some situations like severe congestive heart failure, chronic obstructive lung disease, where giving that person oxygen can stop them from breathing. In a medical emergency, you never hold back oxygen. You always administer oxygen during a medical emergency. It's these other drugs, if you're not sure, do not give the patient. When in doubt, don't medicate. Don't panic. If life is full of lemons, make lemonade out of it, whatever. But don't panic. You know, and again, when in doubt, you do basic life support. Hey, that's what it's called, basic life support. I mean, your job is to keep the person alive. Basic life support does that. It doesn't always make the person better, but it keeps them alive, and that is my obligation to the victim. It's keep them alive. You do whatever steps are necessary to keep that person alive. Now, when it comes to emergency drug kits, again, I'm talking about the United States. We got companies out there who are willing to, they have beautiful kits. They got stuff in this kit. And you know what? They got too much stuff in these kits. Way too much stuff. It's crazy. These kits are dangerous. Literally, there are weapons in this kit. Weapons. This is called a laryngoscope. Some of you know what laryngoscopes are. They're weapons. If anybody in this room ever goes to work as a dentist in a hospital, they have a clinic in a hospital, you're doing restorative work. You're a surgeon. You don't do restorative work, okay? But the patient comes in to have their gallbladder taken out, to have orthopedic surgery. The anesthesiologist comes in. Now, let's say it's July 1st, because July 1st in America is the day residency begins. This is your first day as a resident in anesthesiology. You've never put a tube in a patient's trachea before. You pick up this device, whether it's metal or plastic is irrelevant. The patient is unconscious. They've been given a drug that paralyzes them so that they're not breathing. You put this in the patient's mouth, and if you do it right, there's a handle on here, and there's a blade that goes in the patient's mouth. You simply lift up like this. You just simply lift the mandible up. And now I can see the trachea, and I can put this tube in. That's called intubation. The rookie, first time around, and sometimes even later, they put it in the patient's mouth, and instead of lifting up, they do this. Now, when they do this, teeth numbers 7, 8, 9, and 10 just break off just like that, and you've seen this happen. Now, as a dentist, okay, so it's, look, the patient has a surgery done, their hip is taken care of. You get the referral in the dental clinic. The patient needs endo and/or extractions, blah, 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 blah. That's a weapon. You're not trained, most of us are not trained to use this. You don't want this in the kit. They'll sell it to you. You don't want it. Lots and lots of drugs in these kits that have to be given intravenously. And a lot of those drugs are for cardiac arrest. Wait a minute. What is the patient's blood pressure in cardiac arrest? 0. Okay, so patient has a cardiac arrest, you're doing CPR, and then they're going to ask you to start an IV. Wait a minute, when the blood pressure is 0, the veins collapse. Are those drugs any good to you? No. You don't want them. See, you don't want these kits. There's too much in there. Make your own. This doctor made his own kit. Look, there it is. It's beautiful. It's not good. Maybe it's not good for me, but it's good for the one who made it. This doctor looked at what his training, her training, and said, this is what I want. This is what, for this doctor, this is a very nice kit. And by the way, I look at this kit and I say, I'm not sure what drugs are where. But you know what? If I made that kit, if I made the kit myself, I know what those drugs are. That's the best way to go. You make your own. I'll be glad to sell you a kit. I don't make a kit, I'm just kidding. But I'll be glad to sell you a kit. I make money, you feel secure. But you have to know what the heck you have in that kit. You need to know. Again, individualize it to your practice. A lot of good stuff. You want the drugs accessible. Everybody in America goes fishing, apparently. We have fishing tackle boxes. You have a card in there to remind you the name of the drug and how much to give. The biggest problem, and this is the nicest problem in the world, we don't use these kits. See, it's nice. We have all these wonderful drugs available, but thank God medical emergencies don't happen very often. That's nice. But what happens then is the drugs expire. My adrenaline syringe. Doctor, why is the liquid brown? I thought adrenaline was clear. Yeah, adrenaline is clear, it is. But as it gets older, it oxidizes, just like an apple does when you cut an apple. Epinephrine turns yellow and it then turns brown. And if you see an epinephrine syringe with any color yellow, get rid of it, buy a new one. And that's nice, we don't use it. It's nice we don't need it, but you have to have it available if you do. So, individualize your kit. Let me talk about emergencies on, there he is, my friend Malamed.
Hay 7 fármacos en un equipo básico, 2 medicamentos inyectables y 2 que no son inyectables. Lo más importante es la epinefrina. La epinefrina tiene que estar disponible en una jeringa precargada. Esta es EpiPen, que contiene una dosis de epinefrina que se utiliza para reacciones anafilácticas en una concentración de 1 a 100. Las reacciones anafilácticas son muy comunes. En este caso es muy común utilizar más de una dosis y por eso recomendamos que además de tener una jeringa precargada, el médico que tiene un equipo para emergencias conserve 2 o 3 ampollas de epinefrina de 1 a 1000, con una proporción de 1 a 1000. La única indicación de la epinefrina de 1 a 1000 es una reacción anafiláctica porque la anafilaxis amenaza la vida. Todos los medicamentos tienen contraindicaciones. Con la epinefrina y para la reacción anafiláctica no hay contraindicación para su aplicación. La reacción anafiláctica, en este caso, las personas que reciben más pronto la epinefrina sobreviven. Quienes no la reciben o no la reciben con suficiente celeridad no sobreviven. Y por eso es que se tiene que tener epinefrina en una jeringa ya cargada, y por eso es que no hay contraindicaciones para este medicamento que salva la vida. La segunda medicamento es un bloqueador de histamina. El Benadryl es el que se utiliza con mayor frecuencia en los equipos para emergencias. Los bloqueadores de histaminas se utilizan para las reacciones alérgicas, pero se utilizan principalmente en reacciones que no amenazan la vida. También se puede utilizar en la reacción anafiláctica después de que se ha salvado la vida con la epinefrina. No hay contraindicaciones para la administración del bloqueador de histamina en una emergencia, y porque no hay urgencia de aplicar el bloqueador de histamina, no recomendamos que este medicamento esté disponible en una jeringa precargada. Hay suficiente tiempo para poder romper la ampolla, rellenar la jeringa y administrarlo. Hay otros medicamentos que no son inyectables en un equipo básico. Un dilatador, un vasodilatador, esto es la nitroglicerina. El paciente que sufre de angina traerá consigo su propio nitroglicerina, generalmente en forma de tableta. Recomendamos, sin embargo, que un equipo básico de emergencia tenga un spray nitrolingual. Una aspersión es equivalente a una tableta. Se asperja en la lengua del paciente y así aplica la nitroglicerina. Sin embargo, hay 2 contraindicaciones a la aplicación de nitroglicerina. Uno es un paciente que sufre de dolor de pecho con una baja evidente de presión sanguínea. En ese caso no aplica nitroglicerina. La otra contraindicación es un paciente que tiene dolor de pecho, que ha tomado Viagra durante los últimos 24 horas. Ambos medicamentos pueden bajar la presión sanguínea y si el paciente sufre o toma nitroglicerina y ha tomado Viagra en las últimas 24 horas, puede bajársele más aún la presión sanguínea. Un broncodilatador es otra cosa importante. Un broncoespasmo es un ataque asmático agudo que le puede ocurrir a los pacientes. Generalmente los pacientes van a traer su broncodilatador con su inhalador, pero si no lo trae o si el paciente viene sin historia de asma y sufre de un broncoespasmo, tiene que tener un broncodilatador en el equipo. El medicamento que se utiliza generalmente en los Estados Unidos es albuterol. Las dos marcas son Ventolin y Proventil. El medicamento viene con un inhalador y después de colocarlo en la boca, a medida que inhala el paciente, va a comprimir el asperjador y el medicamento lo inhala a los pulmones y generalmente en cuestión de 30 segundos o un minuto el broncoespasmo habrá desaparecido. Otro medicamento para el equipo de emergencia es el azúcar. El azúcar se puede poner a disposición sea en un tubo, esto se llama istaglucosa, o puede tener simplemente una botella de de naranja, jugo de naranja o una agua gaseosa. La istaglucosa es fácil de utilizar si no hay azúcar y lo que se ha añadido más recientemente al equipo de emergencia es una aspirina que es el tratamiento que se utiliza para pacientes de quienes se sospecha que están sufriendo del corazón. Se recomienda que el paciente que nunca ha sufrido de dolores de pecho y está sufriendo de este dolor por primera vez, mastique, no trague, sino que mastique una aspirina. Hay algunos pacientes que son, sin embargo, alérgicos a la aspirina y con si estos tipos de desórdenes no tienen, y una persona que tiene úlcera péptica no debe tomar aspirina. No hay sustituto para la aspirina en esta situación. El último de los 7 medicamentos es la segunda más importante en la medicina para emergencias y ese es el oxígeno. El oxígeno tiene que estar disponible en un cilindro E. El cilindro E es de 3 pies de alto y contiene suficiente oxígeno para ventilar a un adulto que no está respirando durante más o menos unos 30 minutos. También tiene que tener el equipo necesario para entregar el oxígeno al paciente. Y esos son los 7 medicamentos, los 7 fármacos.
The other item that I mentioned briefly earlier is the automated external defibrillator. And I don't know what exposure you've had to these, if any, but you got to get one. You got to get one. I mean, they are the greatest thing in the world. They save lives. Now, we'll demonstrate this a little bit later on this afternoon. You buy one for your office. You buy one for your home. Okay, bottom line is very, very simple. 70% of out-of-hospital cardiac arrests. Remember, at home, in the office, whatever. 70% of cardiac arrests that occur not in a hospital occur in the home of the victim. 70% occur in the victim's home. Now, I'm thinking as a dentist, I have 2 homes, the one in which I live and the one in which I work. I spend the vast majority of my time in those 2 places. That's the way you're going to think. If I were to have a cardiac arrest, it is most likely to be in my dental office or in my home. I want to be prepared. I want to live. I'm only 59. I'm only 62. I'm only 70. 70 used to be old. It no longer is. Now, if you're 20, 70 is ancient. If you're 20, 30 is old. Now, if you're 30, 30 is young, isn't it? Yeah? 40 is old. Now, if you're 40, 30 is, it's you'll get there. Hopefully, you'll get there, okay? You want to have that device available in your office and your staff trained to use it. And you want to have this device in your home and the people you live with, whomever it is in your family, trained to use it. It's a morbid thing to think about, it really is. But it saves lives. Okay? Think ahead. Plan ahead. So, we are prepared. We have basic life support training, everybody in the room. We have an emergency team. People know what to do. We'll assign tasks. Everybody can do it. We are not going to be afraid to call the ambulance service that you have signed up for. What about if you've had ambulance service and you have an emergency, let's say, in your own house? Do you still call that same ambulance service? So they are your ambulance service regardless. Okay. So you would call that person, and now we have to face the problem. What do we do for specific emergencies? Now, very, very simply, the first thing we're going to do is we assess the patient. We have to recognize the fact that something is wrong. And I'll tell you right now, there are two emergencies that are really, really easy for a dentist to handle because the patient diagnoses it themselves. Asthma. The patient has a history of asthma. On their medical history, they circled it. They carry their inhaler with them, hopefully, and they're lying in your chair, and their airway narrows down. It's called bronchospasm. And you know what they're going to do? They're going to sit up. They're lying down. You're busy working in their mouth. And the patient pushes your hand away and starts to sit up on you. John, what are you doing? I'm having an asthmatic attack. Isn't that easy? They're diagnosing it for you. Now, I can see you as a young doctor in America. Oh my God, asthma. John, call 911. And the patient looks at you and like you're crazy. Doc, you know, I'll speak normally, but they're speaking like this. What we do in the United States, remember, I don't practice dentistry, okay? What we do in the United States is we call our patients up a day or two before their appointments to confirm. You know, this is Dr. Malamud's office. Just a reminder, you have an appointment on Thursday at 1 o'clock in the afternoon. Okay, that's what we do routinely to remind the patient. If the patient has a problem like angina or asthma where they bring their own medication with them, we remind them. Just want to remind you to bring your inhaler with you. Well, the asthmatic is going to say to you, of course. They have it with them all the time, but just remind them. Okay? Remind the patient. That's one. The other one is angina. The patient has a history of angina. And when you make the telephone call to confirm the appointment, you remind them to bring their nitroglycerin with them. Oh, don't even ask me. I always have it with me. And when the patient has an anginal attack, oh my God, you the young doctor, oh my God, he's having chest pain. Mary, call 911. Now in this case, the patient looks at you and says, Doc, don't call 911. I have my nitroglycerin. I'll take a tablet. You know, Dr. Malamud, maybe you should take one too. You know, that's why those are two easy emergencies. The patient diagnoses it for you. The third one that is easy is fainting. Now, fainting is not easy initially because it's unconsciousness. But it's easy because once you position the person, reestablishing the blood flow to the brain and maintain the airway, they wake up. That's easy because you diagnose fainting by how they respond to what you do. Some emergencies are easy, others are not. I'm not going to go through the entire list because of the time factor, but let's talk about the basic management of every medical emergency. We'll go back to basics here. How do you handle any medical emergency?
Todas las emergencias médicas se manejan fundamentalmente de la misma manera. El algoritmo para tratar las emergencias médicas son PA, B, C, D. P quiere decir posicionar al paciente, A en inglés, vía respiratoria, B, respiración, C, circulación y D, atención definitiva. Todas las emergencias médicas exigen posicionar o poner a un paciente en una postura que sea adecuada. En el caso de una persona que no está inconsciente, hay que ponerlo en una posición que se sienta cómodo y eso está muy bien en un paciente que está consciente, pero alguien que sufre de dolor de pecho, donde sienten un peso peso en el pecho, lo más frecuente es que se quieran sentar, siempre y cuando el paciente siga estando consciente. Cualquier posición que ellos elijan es buena. En un paciente inconsciente, la posición supina es la mejor, es decir, horizontal, con los piernas levemente elevados. La presión sanguínea baja es el principal problema en un paciente que está inconsciente, y por eso es que al poner al paciente en esta posición supina, se incrementa el flujo sanguíneo al cerebro. No quiere poner al paciente en una posición donde el corazón esté más elevado a las piernas, porque impide que la respiración sea buena. Entonces, horizontal o supina son las mejor, con los piernas levemente elevadas es lo mejor para un paciente inconsciente. El manejo de las vías respiratorias es muy importante, sí, porque el paciente que está consciente puede hablarle, y entonces sabemos que las vías respiratorias están abiertas, y porque está consciente sabemos que en ese sentido está bien. En el momento en que el paciente le habla, hemos evaluado la vía respiratoria, su respiración y la circulación. Con solo escucharle al paciente sabemos que las vías respiratorias están abiertas, que puede respirar y que el ritmo cardíaco está funcionando. Así que no tenemos que hacer nada físicamente ADOC en un paciente consciente. Sin embargo, cuando una persona está inconsciente, los músculos se relajan, y puesto que la lengua es un músculo, tapa la vía respiratoria, y las vías respiratorias de las personas inconscientes se ven parcial o totalmente obstruidas de esa forma. La gestión de las vías respiratorias es de una importancia crítica para salvar la vida de una persona que está inconsciente. La técnica para mantener las vías respiratorias de una persona inconsciente es muy sencilla. Se llama inclinar la cabeza y levantar el mentón. Dos dedos bajo el mentón y una mano sobre la cabeza, el cráneo, y le elevan la cabeza como lo mostramos. El siguiente paso en el paciente inconsciente es verificar para ver si están respirando. La respiración se define como el intercambio de aire, y aire que entra, aire que sale. La inclinación de la cabeza se mantiene. La persona encargada del rescate tiene que colocar su oído a una pulgada de la boca del paciente, y está viendo el pecho del paciente para ver si está tratando de respirar. Un concepto muy importante: ver que el movimiento del pecho no quiere decir que está respirando, porque puede ser que todavía esté obstruido las vías respiratorias, pero el paciente está tratando de respirar y el cuerpo hace esto automáticamente. Así que ver que el pecho se está moviendo no quiere decir que está respirando el paciente, y por eso es que tiene que colocar su oído a una pulgada de la nariz y la boca y sentirlo y oírlo. Si siente aire que está saliendo de la nariz y de la boca, y las vías respiratorias entonces están abiertas. Si no se está moviendo el pecho, el paciente no está respirando. Eso es evidente. La persona encargada del rescate tiene que darle 2 ventilaciones completas para que entre oxígeno a los pulmones del paciente. Después de hacer eso, ahora ya tiene oxígeno en el flujo sanguíneo, y después la circulación, ver si esa sangre que contiene oxígeno está llegando al cerebro del paciente. Al mantener la posición inclinada hacia atrás de la cabeza, tenemos que saber que es muy importante que un médico o un encargado de la salud tiene que localizar la carótida. La carótida ha demostrado, los estudios han demostrado que 40% del tiempo los asistentes médicos no encuentran el pulso. Ellos colocan los dedos donde creen que debería estar la arteria carótida y no están ahí. Entonces creen que hay pulso y tal vez no lo hay. O cuando no hay pulso, ellos creen que sí lo hay. Así que es sumamente importante para las personas que brindan servicios de salud localizar la arteria carótida. Así que localizar la carótida manteniendo la inclinación hacia atrás de la cabeza. La otra mano se coloca en la manzana de Adán y se mueve hasta que los dedos llegan a la hendidura, y la carótida está localizada en esa hendidura. y se sostiene durante 10 segundos la carótida. Si el pulso no está presente, entonces inicia las compresiones del pecho. Ahora está circulando sangre que contiene oxígeno, está llegando al cerebro. El último paso en el manejo de emergencias médicas es la atención permanente. Los primeros 4 pasos, el posicionamiento, la respiración, la circulación, son aspectos para darle apoyo. Ahora tenemos que asegurarnos de que el cerebro esté recibiendo un flujo constante de sangre con oxígeno y estamos manteniendo vivo al paciente. Y luego la atención definitiva. ¿Cuál es el problema? Lo estamos manteniendo vivo y ¿cuál es el problema? Esto quiere decir diagnóstico. Si el médico puede diagnosticar el problema y si el médico tiene los medicamentos y el equipo necesario, entonces dele tratamiento. Si no puede realizar el diagnóstico, entonces llame al 911. Si puede diagnosticar y no le gusta lo que ve, también llame al 911. Recuerde que su obligación jurídica durante una emergencia médica es mantener vivo al paciente hasta que se recupere o hasta que venga alguien que esté mejor capacitado que usted y se haga cargo de la situación.
PABCD. Again, the most important thing, if you are learning how to save a life, this is it. It's PABCD. Positioning the victim appropriately, assessing the airway. I said this on a tape. B is breathing, C is circulation. Let me ask somebody in the very last row back here. Is my airway open? The back row, the lady next to the back row right over there. Yeah, the one who's looking to her left. Is my airway open? Am I breathing? Yes or no? I'll help you. Is my heart beating? Yes. How do you know? I'm conscious. You got it? I'm conscious. My brain is receiving a constant supply of blood which contains oxygen. Speech is breathing. The moment your patient says to you, I'm dying, you've assessed their airway, you've assessed their breathing, and you've assessed their circulation. Yes, you're dying, but it could be worse. What's worse than saying you're dying? It's being unconscious. Remember, nobody ever died while they were still conscious. Got it? A patient having a medical emergency who's still conscious is better than an unconscious person. Immediately, they're better. So that's what we're going to do. Positioning, airway, breathing, circulation, and definitive care. That's basic life support. Remember, the first thing you do in the treatment of every medical emergency without exception is basic life support as needed. The most important thing that we do. And then, because we are doctors, we're not people on the street, we are doctors. Our obligation goes a little bit beyond just basic life support. Again, definitive care. If you can make a diagnosis, if you have the appropriate stuff, treat the patient. If you don't know what's going on, call for help. Simple. Keep the victim alive until help arrives on the scene. Again, the way you determine unconsciousness is shake and shout. You've had your CPR class or classes. You have that mannequin, her name is Resusci Annie. Don't you feel stupid? Annie. What if Annie said I'm okay? We'd have a real cardiac arrest, wouldn't we? Okay, look. You know, it is kind of stupid. You don't walk over and go, John, are you all right? You don't do that. Look, when you go home to visit your family, and I know it's true all over the world, doesn't Dad have his chair? Is that true in Guatemala? Dad has his chair. And when Dad comes home at night, he sits in his chair. And what does Dad do when he sits in his chair? Right? He falls asleep. Now, when you walk in the house and you see your father sitting in that chair, do you run over to your father and go, Dad, are you all right? You don't do that because Dad's going to wake up and smack you. He's sleeping. How do you know he's sleeping? He's snoring. Snoring is breathing. It's not the best breathing, but it's breathing. Now, if Dad were not snoring, he's just lying there, you'd walk over and you'd go, Dad? Because you think he's sleeping. You don't want to wake him up, right? Dad, hey Dad, wake up. Now, if Dad didn't wake up, wouldn't you do it a little bit, Dad, right? Dad. Okay, that's the reality of shake and shout. I mean, in a dental chair, your first patient comes in at 7:30 in the morning. Your dental assistant puts them in a chair at 7:25. Hell, for most of you, you haven't even gone to bed yet. The patient's in the chair and they go to sleep. You don't walk in the room and shake and shout. You go, hey, Michelle, wake up. Right? And she wakes up. That's shake and shout. Now, if Michelle didn't wake up, you'd shake her even more. Now, if somebody's lying under a ladder in a weird position, you don't assume sleep. You assume something different. If they're lying on a floor in your bathroom, you don't assume they're sleeping. Right? So in other words, it depends upon the situation. Shake and shout. Now, the positioning, of course, since the most common reason a human being becomes unconscious is the brain is not getting enough blood. That's the most common reason by far. Take the tallest building in this country, whatever the building is in this country. The cause, low blood pressure as a cause of unconsciousness is at the very, very top of that building. The second most common reason for unconsciousness in human beings is on the ground floor. So if the building is 40 stories tall, or 50, or whatever it may be, all the way down to the first floor is the second most common. Now, everything else that produces unconsciousness is 30 stories underground. In other words, there are two things that cause unconsciousness. By far, number one is low blood pressure. And that's the reason you always lay the patient down flat, always. You get an increased supply of blood to the victim's brain. Now, the second most common reason is low blood sugar, hypoglycemia. Now, I'm not going to discuss that here today, but again, unconscious patient, positioned properly. Conscious patient, any position they want is okay. A patient with chest pain, a patient having difficulty breathing is going to sit up automatically. Guaranteed they're going to sit up. And the reason they sit up is they can breathe better. Unconscious patient, you always lay them down. Now, unconscious patient, head tilt, chin lift. Why? Muscles relax when you're unconscious, tongue falls back in the airway. Tongue is attached to the mandible. If you lift the mandible, the tongue is lifted with it. Simple step, the most important. They're all important steps. They're all important. Very important step. Unconscious patient, look, listen, feel. Are they exchanging air? Are they exchanging air? And because breathing is very, very quiet, you've got to put your ear an inch away from the victim's mouth and nose. Because you have to feel it. You have to feel the air against the side of your face when they're breathing. See, they don't breathe like this. They don't. You've got to get right down against that person's face. And if they're not breathing, the last thing in the world you want to do is mouth to mouth. You do not. Now, you may have to do it. It's your mother, it's your father, it's your child, it's your spouse. You would do it. Of course you would do it. By the way, we never tell you in your CPR classes, we never tell you this, but when that person is unconscious and not breathing, their mouth is filled with vomit. Yeah. Yeah, it's filled with vomit. Think about mouth to mouth. Now, we teach our people at USC, we call it a barrier device. We use a mask. There's no reason why every person in this room should not be able to hold a mask on a patient's face. Covers the patient's mouth and nose, to hold a mask on their face and lift the chin with one hand. It's head tilt chin lift. And then what you do is you put your mouth on there and you blow. And you blow until the chest rises. That's it. That's easy. Hey, a vomit, you've scooped out the... That's what you do, mouth to mouth. Come on. Look, think about something. Think about dental school. You're in the middle of doing a crown or a bridge, or you're doing some perio on a patient. This may sound kind of weird, but in the middle of your dental procedure and you're doing all that stuff in their mouth, would you want to kiss them? Would you want to, in the middle of doing an incision and drainage, would you want to, excuse me, I don't think so. I really don't think so. And that's what you're doing here. This is what you're doing. You're getting up close and personal with this person. You should be taught somewhere along the line to ventilate with a mask. Then the blood in the mouth, then the amalgam, then the calculus, then the pus won't bother you because you're not physically coming in contact with it. Again, if there's no pulse, you start doing chest compression. This last scenario is unlikely to happen. Chest compressions, as I mentioned a little bit earlier, the new guidelines in effect as of December 2005, the ratio of chest compressions to ventilations for an infant, for a child, and for adult is 30 compressions to 2 ventilations, 30 to 2. And there are some reasons behind it. I'm not going to spend the time to go into it right now, but it's a scientifically based thing. Then definitive care. Now, definitive care, I have emergency medical services. I don't have 911 here. I was in Australia 3 weeks ago. 911 doesn't work. 000 does. Every country has its own system. And by the way, in Australia, they get a lot of American TV shows, and what I was told by paramedics, 30% of emergency calls in Australia are to 911. And you know what they've done because of that? If you dial 911, it automatically connects you to 000. The Americans have screwed up the health system in Australia. See that? Okay, so let's go through a couple of situations. Now, I'm going to start us out with the most basic, most common medical emergency, and then take us around in a circle. We're going to start out with the unconscious patient. We're going to finish with the unconscious patient. We're going to start out with the most simple unconsciousness, which is fainting, and finish up with the worst, which is cardiac arrest. And we'll stop at a couple of places along the way. Unconsciousness, fainting, usually occurs when the blood supply to the brain is inadequate to maintain consciousness. The brain, in order to function, needs a constant supply of 2 things, oxygen and sugar. Blood carries both. So if the blood pressure drops, the brain is now being deprived of the 2 things it needs, and unconsciousness occurs. Now, if a patient is a diabetic, and if they take insulin to lower their blood sugar, and if they take insulin and don't eat immediately following taking their insulin, they become hypoglycemic. The blood pressure to the brain is still good, and the blood contains oxygen, but it doesn't contain the other fuel. And you cannot maintain a normal level of consciousness if the brain is not getting sugar. And in hypoglycemia, very often the person is conscious, but is behaving strangely. You can't function normally without enough sugar. Take away enough sugar, and the brain ceases to function normally, and the patient becomes unconscious. Bottom line, we're dealing with the brain. We're dealing with the brain. The most common reason in a dental environment for loss of consciousness to occur, back to the old basic one, fainting, syncope, vasodepressor syncope, vasovagal syncope. Fainting is what we're dealing with right now, the most common reason in dentistry. Most often during injection. This is the 20th time I've said this today. Most commonly during injections. There are other reasons for it happening, but by far, remember, in my survey, over 50% of all the emergencies, over 15,000 out of the 30,000 emergencies were fainting. The second most common was 2,500. 15,000, and number 2 was 2,500. Far and away the most common thing we see in dentistry. Well, how do you treat it? You recognize the loss of consciousness. Now, you know what most doctors say to me? I was giving the patient an injection, and here's the quote. His eyes rolled up into his head. The pupils of his eyes just disappeared. Okay? His eyes rolled up into his head. Recognize unconscious. John, are you all right? No response. Then what? You place the patient into a supine position. The back of the dental chair is horizontal. Automatically, in most modern dental chairs, when you have this part of the body parallel to the floor, the feet are elevated, and that's good because gravity takes all the blood out here and it goes downhill back to the chest and to the brain. This is an ideal position for any unconscious patient. You leave them in a dental chair, you simply place the chair horizontal again, which is called the supine position. You assess breathing. Head tilt, chin lift is being done. Assess breathing. And you know what's going to happen? Look, listen, and feel. The patient, if needed, you're not going to have to do this. We're just demonstrating doing ventilation. You check the circulation, the carotid pulse, and the patient is going to recover within a matter of 10 seconds. 10 seconds, 15 seconds maximum. Young, healthy, macho. You understand it's a Spanish word, macho. The macho dude. I guess the female version is macha. The macha dudette. I don't know. But, you know, anybody can faint. It's males who faint. It's males who faint because half of the dentists in your country, in my dental school now, thank God it's half female. I went to dental school in a time when we had 162 students in my dental school, 1 female. Oh my God, was this horrible. It was just such a terrible. So a guy comes in, this macho teenager, he's a football player, soccer, football, real football, okay? Macho dude, he comes in, he's sitting in the chair of one of the lady doctors. Is he going to say to you, by the way, I'm afraid of getting a shot? There's no way in the world. He's going to sit there like that, and you didn't listen to me, you sit him up. Doc, I just don't want to see the needle. You ever hear that? I don't want to see the needle. So you're good, you keep it down here. Now, you know and I know that the more a patient says to you, I don't want to see the needle, the more they look for it. You're hiding it, and they're doing this. And that's when they faint. That's when they faint, okay? You position the patient, the blood supply to the brain has been increased, and quite literally 10 or 15 seconds, they're back. They're back. Very, very simple. Easy to do. Again, find out why it happened. Now, it was obvious, the syringe. But maybe it wasn't. Maybe something else. John, what happened? Now, what I hear very, very often from patients, remember, I get called down to when the emergency happens. Here's what they say to me. I'm quoting exactly. Doc, I thought I could handle it, but. In other words, you're doing perio, you're doing endo. They were scared, so they internalize their fear. They keep their fear hidden. They're trying to handle it. They couldn't. How do we know they couldn't? Because they lost consciousness. You know, if you had told me about this before, this wouldn't have happened. This wouldn't have happened. We could have used nitrous oxide, we could have done hypnosis, we could have done something to take away your fear. It's only when the patient keeps that fear hidden that these things happen. Okay? Keep that in mind. Before you go back to treat the patient, find out the reason it occurred. Again, psychogenic fear, fright, anxiety, emotional stress. Oh, this is a good one. Pediatric dentist. Pediatric dentist. Here's a very important rule. Healthy children do not faint. Healthy children do not faint. Period. Reason. They're children. If your child is scared of going to the doctor, medical or dental doctor, do they hide it? They're screaming. You're dragging this kid who's fighting and spitting and kicking. And that's why they don't faint. It's when you sit still and don't move, that's when you faint. These kids don't sit still. Healthy children do not faint. In a pediatric dental office, the parents faint. Dad faints. Dad brings the kid to the office. Kid's in the chair. Many pediatric dentists allow the parent to be in the room with the child. It's a way of behavior management. So they're sitting, the patient's over here, the doctor's over there, the assistant's here. The parent is sitting at the foot of the chair. Big macho dad. And you're going to give his kid an injection. And he sees that needle. Dad sees the needle. You put this piece of gauze in their mouth, a 2x2, 4x4. It's white. It comes out red. That's what happens. It's not mom. It's not mom. You know, because mom changes the diapers. Mom cleans up the vomit when the kid vomits. It's dad. Dad just faints away. That's what happens. Males usually, now females can faint, but usually it's males. Usually in this macho, this is the macho age group. You know, once you get beyond 35, you give up on macho. You've been machoed out. You've had it. You know, Doc, I'm afraid of getting shots, okay? You don't mind. I'm getting tired of fainting all the time. Male gender, ages 16 to 35, most likely candidate to faint. What's going to happen? Massive vasodilation. You're going to be perspiring. You're going to get very, very warm. As your blood pressure drops, your skin becomes pale. The patient, again, may feel nauseous. They feel faint. They see spots in front of their eyes. The heart rate begins to go. The patient doesn't know their heart rate's going up, but if you measure their pulse, the heart rate begins to go up. As it progresses, the pupils dilate. The patient begins to have, the hands get cold because of the drop in blood pressure. BP begins to drop. The rate of the heart goes down, and the victim loses consciousness. Very simply, the patient is now unconscious. So again, you do your shake and shout. You position the victim appropriately. Supine position. Maintain the airway. Assess breathing. Assess the circulation. Do whatever is needed. And what is going to happen is if the patient does not recover rapidly, activate emergency medical services. The average person, the typical patient who faints, will recover consciousness within 15 to 20 seconds. Now, I'm not saying to you they're going to be fine. It takes a long time to fully recover, but they're conscious again within about 10 to 15 and no more than 20 seconds. And that's it. Oxygen, of course, is always good, and monitor the vital signs, and that's it. This is all you have to do for a patient who fainted, which again are the things that are going to happen. This emergency is going to happen to every dentist in this room at some time during their practice career. Once the patient recovers consciousness from a faint, they feel lousy. They are, first of all, they're sweating, their clothes are wet. They have a headache. They're nauseous. You're done. John, do you want to continue? Excuse me one moment, doctor, while I throw up. Blech. No, I don't really think I should sit here anymore. I want to go home. Simple. The problem is after the patient recovers consciousness, you cannot allow that person to drive their... Again, I'm talking about America. 100,000 attorneys in California, 30,000 of me. You cannot allow a person who was unconscious, even for a second, to get in that car and drive their car home for a simple reason. It takes the human body 24 hours to fully recover from faint. 24 hours. And they are more likely to faint in that period of time. They feel lousy. Okay, that's America. You can't allow that person to drive their car home. If recovery is delayed, now look, let's take a person who is 75 years old, who appears to faint. Fainting can happen in 75 years old patients, but you know what? They're 75, they're not 16. And there would be no problem if the patient were 75 for you to call 911, because you know why? There might be an underlying cardiac problem in that older patient. Depends upon the situation. 16-year-old recovers rapidly. I'm saying, you know what? Healthy person scared. 75-year-old could be scared, but they're 75 years old. This ticker has been ticking, not for 16 years, but for 75 years. Things get old. This is getting depressing. They don't work as well. I mentioned pneumonia I didn't even mention it. I sort of let it go by, didn't I? But you read it. You know, the smelling salts we have, I didn't even mention them as part of my 7 drugs. I didn't mention them at all. And the reason is you don't need them. A patient who faints recovers consciousness with positioning and airway. You don't need it. Now, if anybody ever washed the floor in your house? I don't do it very often. I never do it now. I just give up on that. I can't get up again. But the point is, my wife would get mad at me and she'd say, God damn it. She doesn't say that. My wife never says that. She doesn't. She doesn't have to. She gives me the look. Now, I see a lot of you aren't married, but if you're married, you understand the look. You're in trouble. You don't know what you did, but you are in trouble. I get the look. I could be away for 4 days. Like I come home, I get the look. I didn't do anything. I've been in Guatemala. No, you did something 2 weeks ago, though. Women never forget. I don't want to go there. A guy, you have an argument, 10 seconds later, it's gone. You never forget. And that's the worst possible thing. 3 weeks later, I'm still mad at you. The list is this long. Which one did I do? Which one is it? You know. But the point is ammonia. It stinks. When you breathe ammonia in, you move away from it. Now, when you move away from it, you're using your muscles. And what it does is it stimulates movement. And movement of muscles pumps blood back to your heart. That's what ammonia does. You don't need it, but if you have it, it speeds up the recovery. You don't need ammonia. It's on there, but it's not really a very important medication in this situation. Again, so what do? Prevention of syncope, proper positioning of the patient for an injection. This would not be the proper position. Again, it's a good position to make the injection work, but it's not a good position for fainting. That person is more likely to faint. And if the patient is scared, depending upon what you are allowed to prescribe, if you can prescribe oral sedative drugs, there are lots and lots of very good medications out there. Whether it's nitrous oxide oxygen, inhalation sedation, or some kind of a anxiety-controlling pill. Preventing this is much more important than actually having to treat it. Asthma. The asthmatic patient. And again, what we're dealing with is a patient, we have the trachea, the right and left main stem bronchi, smaller bronchioles, and even smaller bronchioles, and finally what are called alveolar sacs. The alveolar sac is where you actually breathe. That's where you exchange air. Oxygen goes in and CO2 comes out. In a normal airway, the trachea and the bronchi are cartilaginous tubes. Your trachea, by the way, if you want to estimate the size of your trachea, look at your pinky finger. When I'm going to put a tube into a young child's airway, we look at their pinky finger and we take a tube the size of that finger. And that will usually fit into the trachea of that patient. So it's a nice tube that's open. It's a cartilaginous tube surrounded by muscle. Hey, come on, think about this. You have been breathing all day today. Yes? Yeah, the answer is yes, okay? And you've been breathing, in fact, that's even better. You've been breathing your entire life. Have you ever gotten tired of breathing and said, you know what? I'm going to take a half an hour off. I'll simply stop breathing for half an hour and I'll start again later. Now, when you work in the garden and you get tired because your muscles get tired, interesting. You're using your diaphragm and your intercostal muscles when you breathe. Those are the muscles you use with normal, quiet breathing. The diaphragm and the intercostal muscles. They never get tired. Well, look at the right-hand side of the screen. What happens in the acute asthmatic attack is very, very simple. The actual name for it is bronchospasm. The muscles surrounding the bronchi go into spasm, and it narrows down the airway. Can you imagine if you were limited to breathing through a very small, a cocktail straw? You had to satisfy your body's needs for oxygen breathing only through a cocktail straw. That might be kind of hard to do. And don't you think you'd be working hard at getting air in? And don't you think after a while you might get tired of doing that and your breathing becomes weaker? That's what happens in the asthmatic attack. You're breathing through a very fine straw. You're fighting to get air in. You're fighting to get air out. You're not getting enough air in. You become hypoxic. You don't get rid of all your CO2. You become hypercarbic. You begin to get sleepy because of that. Your airway is now obstructed. You're dead. Asthma is not a nice thing. You know, you see the advertisements on television for whatever the medication is, 1 puff, 2 puffs, and the patient's fine. Yes, most of the time it works well. By the way, the drug you take is called a bronchodilator. Hello, the problem is called bronchospasm. Bronchospasm, you give a bronchodilator. But there are times when it doesn't work. And that's when patients die. Serious problem. Again, the problem is due to narrowed airways, and there are some certain signs and symptoms, wheezing, difficulty breathing. I guarantee that the asthmatic patient is going to sit up. Guarantee they're going to sit up when they have the asthmatic attack. 2 types of asthma. We have allergic asthma. About half of all asthmatics have allergic asthma. Their asthmatic attack is an allergic response to something. Very commonly it's aspirin. It could be to dust and dander and certain kind of foods. The other half of asthmatics have the same response, bronchospasm, but what precipitates it is not allergy. It could be a sudden exposure to cold air, not likely to happen here. It could be fear, anxiety, could be exercise-induced asthma, stress-induced, dental office, stress-induced asthma. The problem they have is exactly the same. It's called bronchospasm. What brings it on is different. Clinical manifestations, a feeling of tightness in their chest, coughing, wheezing, SOB, shortness of breath. That's what it means, shortness of breath. They get nervous. Hell, I would be nervous if I couldn't breathe. They get nervous. They breathe faster. Their heart rate goes up. The patient will guarantee want to sit up or stand up. Now, if you were to sit there right now and on purpose take a really deep breath, you can feel your abdominal muscles. You can feel your neck muscles. I don't know if you can feel your back muscles. But when you have difficulty breathing, you begin to use what are called the accessory muscles of respiration. Abdomen, neck, and back. Now, think about something. Does anybody here belong to a health club? Anybody belong to a health club? Anybody go and you lift weights occasionally? See? No? Yeah, okay. We all do curls with 16-ounce beers. You know? Okay, not a good way to go here. If you do not use muscles on a regular basis, and you go out to use them, the muscles fatigue very, very easily. You've been using your breathing muscles, the diaphragm and intercostal muscles, nonstop your entire life. They never get tired. But all of a sudden, I can't breathe. I begin to use these other muscles. These muscles work. They work. But if the asthmatic attack doesn't stop in a hurry, these muscles that I don't use very often fatigue. Asthma that goes on and on and on is life-threatening. That's the important point. What do? You position the patient comfortably. They're going to sit up on you, guaranteed going to sit up. Airway, breathing, circulation are not needed because the patient is still conscious. Definitive care, very simply, is allow the patient to medicate themselves. They brought their inhaler with them, their bronchodilator. Whatever drug you're using here, they have it with them. If anybody in this room has asthma, you have your inhaler with you. It could be 1 puff, it could be 2, it could be 3, whatever they need. Simple. Let them medicate themselves. By the way, if the asthmatic patient ever says to you, Doc, call the paramedics, you believe them. Because they know their asthma. They know. And if they ever said, I want help, I'm going to get help right now. If the episode terminates, it's over. It's okay. You can continue with the planned dental treatment. Once the asthmatic attack ends, once the bronchospasm goes away, the patient's fine. Find out why it happened. Well, doc, I thought I could handle it, but find out why it happened and prevent it from happening again. If it's fear-induced, use sedation. If it was a lack of good pain control, get better pain control. Okay? If it doesn't end, the patient takes their medication. They take their medication again. Doc, call the paramedics. Okay? Give them oxygen. Call 911 or whatever the appropriate number is. And if you are comfortable doing this, take your epinephrine that we're going to have in a moment for anaphylaxis and give them an intramuscular or subcutaneous injection of that drug. Why? Epinephrine is the best bronchodilator there is. It's the best. It's not the safest. It's the best. You see, epinephrine opens up the airway fantastically well, but epinephrine also stimulates the heart tremendously. And that's why it's not the safest. You see, if somebody has asthma and heart disease, using epinephrine for asthma would be dangerous. It would open up the airway. The asthma is gone. But it stimulates the heart. And if the heart is sick, it's damaged, that could be dangerous. That's why the other medication, that drug called albuterol is safer because it's a good bronchodilator, but it does not stimulate the heart. And that's why it's a better drug. But when all else fails and help is on the way but not there yet, and your patient is having a difficult time breathing, giving a dose of adrenaline will save their life. Period. Lots of things in dentistry can precipitate seizures. Patients who have epilepsy, patients who don't have epilepsy, certain things can trigger seizures. If you ever go to an amusement park and they have strobe lights, or in the old days a disco, strobe lights. Lights flashing at a certain sequence, a certain frequency, can trigger seizures in people who have epilepsy. An epileptic who doesn't eat a meal, hypoglycemia in anybody, if it's extreme hypoglycemia, can induce seizures. Lots of things can do it. Physical stress, alcohol ingestion, especially with a history of seizures, can induce it. So what do? If emotional stress produces a seizure, then what you do in a dental office is you prescribe medicine to prevent the fear. Simple. You can prevent this from happening by taking away the patient's fear. Possible causes of seizures in dentistry: a patient with a history of epilepsy, most likely candidate; a local anesthetic overdose; hyperventilation, a stroke; low blood sugar; a patient who faints, a healthy person who faints. And if you don't position them properly, or if you don't maintain their airway, are going to have a seizure. Now, it doesn't matter what the reason for the seizure is. You treat the seizure in exactly the same way. You've got to treat the problem. Okay, the most likely, again, in a dental office, syncope is a preventable cause of seizures. Now, When Mrs. Jones comes into my office, on her history it says seizures. I want to find out from Mrs. Jones what kind of seizure she has. The most common type of seizure is what we call the grand mal seizure. Now that's a lay term. The actual medical term for a grand mal seizure is a generalized tonic-clonic convulsion. The entire brain, every neuron in the brain is being stimulated, a generalized tonic-clonic convulsion. You want to find out from this patient what medications they're taking to prevent seizures. Dilantin, phenobarbital, and many, many, many others are taken. How well the medication works. In other words, how often do you have seizures at all? What happens to you as your seizure starts? And that's an important question. It's called the aura, A-U-R-A. As the seizure starts, the patient does something. They say something, they smell something, they hear something. My aura is train whistles. I don't have epilepsy. I make believe. I have all these things I make believe. The only thing I really have are STDs. I'm just testing to see if they know what that is. You know what that is? STDs? Good. Just as well you don't know. Sexually transmitted disease. But my aura for epilepsy is whistles. I hear a train whistle. What that means is in my brain, in the area that mediates sound, I have damaged neurons. And when those damaged neurons fire off, I hear train whistles. I know that my seizure has started. Now look where I'm standing. You have about, in my case, 30 seconds. It may be 10, it may be a minute. I don't know. Every patient's different. I've got 30 seconds to get away from here. I'm going to lie down on a wooden floor. The wooden floor is not this. I wish it were carpeting. It's a wooden floor. I'll take off my jacket. I'll fold it up under my head. I'll lie on the floor like this. I will have my seizure. You'll be sitting there going, oh my God, he really had one. Nobody's touching me. I'm safe. I'm safe. There's nothing around here for me to get hurt on. Nothing. My head's protected by my jacket. Leave me alone. That's what happens. Epileptics have seizures. It's not a big deal. They have seizures. Huh? Find out what the aura is. Again, they fall to the ground. If they don't obey the aura, if they don't get away from the dangers there, they fall to the ground. Then they have what is called the ictal phase of a seizure, the ictal phase. Ictal phase is two parts, tonic, clonic. Tonic is a phase when the muscles are all contracted. The victim literally arches their back. That lasts for about 15 or 20 seconds. Then they start convulsing, the clonic phase. Arms and legs jerking. Most of us, when we think of a seizure, think of that clonic phase on the bottom. It's a generalized tonic-clonic seizure. Okay? The seizure ends. The seizure ends, and the patient now stops convulsing. They lie there. They lie there, and now, very slowly, probably over 20, 30 minutes or more, the victim will regain consciousness. Now, they're not unconscious. They are deeply asleep, normal physiologic sleep. If anybody in this room has a sibling who is a very deep sleeper, where you have a really hard time waking them up, that's what's happening here. Very difficult to bring this person back, to have them respond. It takes time to bring them back. Now, how do you handle a seizure? It's easy. It's simple. Because during the actual seizure, what you are seeing during the seizure is central nervous system stimulation, respiratory stimulation, cardiovascular stimulation. That's good. In fact, there's nothing you have to do in the way of airway or breathing or circulation during the seizure. What you have to do during a seizure is protect the victim from injury. And you'll see this on the video in just a moment. That's all you have to do. You keep them in the dental chair and you protect the victim from injury. Once the seizure ends, once it's over, then you go back and you have to reassess the airway. And I mentioned earlier today that snoring means the patient's breathing, but I said snoring is not really that good. Snoring means the airway is partially obstructed. And when a patient, after a seizure, their muscles relax and they're snoring, the tongue has relaxed, it falls back in the airway, and there's a partial airway obstruction. And what you need to do if somebody is lying in that chair snoring is this. And for the translator, again, it's head tilt, chin lift. If you can practice airway management on a real live human being. If you happen to share a bed with a person who snores, they fall asleep and they keep you awake. You know what? You can practice, right? Just practice airway management in that patient. Once you lift the chin up, they stop snoring. Oh, by the way, if it doesn't work, and I will deny saying this. If that doesn't work, then you take the pillow until they stop moving. I deny having said that. Okay? Okay, it's simple. The person with epilepsy in America doesn't have a driver's license. You lose your license because it's dangerous to have a seizure driving a car. So in the reception room is the husband, the wife, or somebody. In this case, it was the parent. Call them in. You're you're protecting the patient. Shall I call the paramedics? And in Mom's case, Mom has seen her son have seizures before, and she said, no, it's okay. If I, the doctor, am comfortable, I won't call 911. Simple. Now, if ever I am scared, I don't care what that parent says. If something about what I see bothers me, I will always call for 911. But again, I have seen seizures. I think some of you have also. See, I'll make you a bet that the first time you see a seizure in your private dental office, you're going to call the ambulance service. It's a guarantee. You know why? It's the first one you ever seen, and you are scared. And that is the reason to call 911 or whatever the number is. If you're scared, you get help. But you know what? Once you've seen seizures, if you've seen 2, 5, whatever, you know what? It's a seizure. I mean, if anybody in this room has a person in their family who has epilepsy, it's a seizure. Hey, Dad's having a seizure. And you take care of it, but you don't call for help. Okay? That's what you do. Very, very simple. There are times when seizures don't stop. Seizures usually stop in under a minute. Less than a minute. However, there are times when seizures do not stop. We call that status epilepticus, a continual seizure. That's life-threatening. You know why? You're burning up oxygen, you're burning up sugar. You're producing carbon dioxide and lactic acid during your seizure. And if a seizure goes on and on and on and on, you're changing your body's physiology. You die. You burn up all the sugar, use up all the oxygen, you're dead. These are the seizures where you have to give drugs. Well, you know what? You got to give these drugs intravenously, and very few persons in this room are trained to do venipuncture. I can't do it. That's when you call for help. We're going to bring Mom back in the room. We're going to bring Mom back in the room, and she's going to see something she doesn't like. Mortality rate. Mortality simply is death. When seizures don't stop, people die. Keep that in mind. You protect them from injury, do basic life support. If the seizure lasts beyond what is comfortable for you. It says 5 minutes. That's by definition. But you know what? I have seen seizures that lasted for a minute. And a minute, if anybody has ever seen a seizure, seems like forever. 5 minutes is an eternity. I would not wait 5 minutes before I call for help. Remember, once you make that phone call, it still takes them X number of minutes to arrive in your office. Okay? So you call for help when you think you need help, and then and I apologize for the red on blue. I apologize for that. It will never be that way again because I know it's very hard to see that. When they arrive on the scene, depending upon who they are, they will inject an anticonvulsant drug, a drug which depresses the brain. And the drug that is used today is a drug called midazolam. Midazolam in America has a brand name of Versed. It's a drug we use for sedation all the time. It's a marvelous drug. They're going to give the drug. It's given intravenously. What you're going to see on the video is something that is interesting and relatively new. They're not going to start an IV on this child. They're going to take that drug, midazolam, and they're going to squirt it in his nose. Intranasal. We have been sedating children. Now, again, this is a weird kind of a thing because we learned this from cocaine addicts. Think about that. They have been snorting cocaine for a long time. They've been getting their high from cocaine by absorption from nasal mucous membranes. It works. We're now taking drugs that sedate people and squirting them in their nose. The option is a needle stick in the leg, and that hurts. We squirt the drug in the patient's nose, the kid's nose. And the drug is absorbed just like an intramuscular injection, and they get sedated. Well, the paramedics started using this a couple of years ago. When I did this tape, these are real paramedics, I didn't expect to see what they did. I didn't know they did this. And it was weird, but it makes sense. If I can use it for sedation, I'm depressing the brain, making you sedate. They can take a seizing patient and depress their brain and make the seizure stop. It's the same exact concept. You know what the most amazing thing and the nicest thing about these paramedics? They stay calm. When you see the last scenario is going to be cardiac arrest, they walk into the office. They're trained, by the way, never to run. Never. Because if you run, you're out of breath. If you walk, you can assess the situation better. But they're cool. You know, mom's panicking, the dentist is panicking. They do this for a living. That's their job. That's why they're so good. They know what they're doing. They know how to handle it. They make you feel better when they come in. That's the important thing. Cardiac disease, number one. Numero uno. Number one cause of death in the United States. 700,000 people died from cardiac disease in the year 2002. Numbers are about the same every year. 650,000, 700,000 people from cardiovascular disease. What we are dealing with in this last 30 minutes is a hollow muscular organ. The heart. It's hollow. Atria and ventricles. And the only function of the heart is to pump out blood. That's all it does. It pumps blood. It's a pump. The right side of the heart pumps blood to the lungs. The left side of the heart pumps blood to every cell in the body. The right side of the heart does about 10% of the entire work of the heart. The left side of the heart does 90% of the work of the heart. Now, the muscle of the heart, in order for it to contract, and you're going to see the heart contracting a little bit later. The heart contracts, all the muscle works together, and it contracts, it looks like a fist, opening and closing. All the muscle works together to squeeze out the blood. The muscle of the heart, the myocardium, heart muscle, gets its blood, remember, the muscle needs blood to keep working. It gets its blood supply from the coronary arteries. Coronary arteries come off the aorta. They run on the surface of the heart, giving off branches that go into the heart muscle. Simple. What we're dealing with is coronary artery disease. It's the stuff that happens inside your coronary arteries as we get older, as we eat garbage. Supersize Me. Anybody ever see that movie? You'll never eat at McDonald's again, will you? Yeah, you will. I know that. That's the problem. See? That's the problem. That movie should have stopped everybody from going into McDonald's or Burger King ever again. That's a different story entirely. Coronary artery disease. The arteries get narrowed down. Remember, that blood is flowing through that coronary artery and supplying the heart muscle. And that heart muscle needs that blood to keep on functioning normally. If the artery gets narrower and narrower, less blood comes through. The muscle on the other side is living with less fuel. Now, you've been sitting here all day and you're at rest. Your heart, even though your coronary artery has been narrowed down by this plaque formation, even though only a little bit of blood is getting through to the rest of your heart muscle, at rest, there's enough blood to keep your heart functioning normally. However, you have a fear. One of the most common fears people have is fear of public speaking, what I'm doing up here. And you know what? I don't know how she's doing this, but I have laryngitis. I can't go on. I can't go on. I have laryngitis. So I take the microphone and I pick who's the most phobic person in the room when it comes to public speaking. I hand you the microphone and say, come up here. And what happens to your heart when you get up here? Boom, 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 boom. Okay, now, your coronary artery is narrowed down. At rest, enough blood is getting passed and your muscle is doing well. Up here, when that muscle is beating 150 times a minute, it needs a lot of oxygen and your coronary artery can no longer supply it. You have what's called acute coronary syndrome. You have either angina or you have an acute myocardial infarction, which is the lay term, which is called by the layperson a heart attack. When there's not enough blood flowing to the muscle cannot function normally. You have chest pain. Angina, the good one, myocardial infarction, not so good. What's even worse? Cardiac arrest. Okay? Angina. The definition of angina is a short-lived chest pain produced by exertion or emotion, relieved by rest or nitroglycerin. That's the definition. A short-lived chest pain produced by exertion or emotion, relieved by rest or nitroglycerin. Once the anginal attack is over, it's done. The patient's as good as new. Treatment can continue. This is not, see, it's a big deal because it scares you. Remember, the patient has a history of this, and that's very important. The only time you as a dentist will ever diagnose a patient as having an anginal attack is if on their medical history they indicate they already have angina. Now, if that's confusing, you'll understand it better in a moment. If they say on their history, I have angina, in other words, they have been diagnosed in the past by their physician. Stanley, that tightness that you felt in your chest, that heaviness, that constricting feeling, we call that angina. When you overexert yourself, this is what happens. What you have to do is not overexert yourself. And when you have chest pain, here, take this pill. It's called nitroglycerin. Okay? The patient knows they have angina. When they're in the dental chair and they have chest pain, they're going to say to you, Doc, I'm having an anginal attack. And that's why angina is easy to manage. If the patient doesn't have a history of angina and they have chest pain for the first time, you never think of angina. Never. You think of the big one. The MI. Always, always. Absolutely guaranteed, always. What you very simply do with angina, again, things that bring it on, anything that increases the workload of the heart. Can I mention that one of the speakers isn't here? Because of the altitude of the city. Is that correct? Somebody with serious heart disease at altitude, almost 1 mile. There's less oxygen in the air up here. By the way, running behind some of those buses this morning, there's no oxygen in the air. Damn, I'm out running this morning and there's this black, may I use the word crap, coming out of those buses? But you're at altitude, and somebody with severe heart disease at altitude has chest pain. They cannot live in a city at altitude because of their heart muscle is damaged. Okay? Smog. I live in Los Angeles, like I should talk, right? Emotional stress, cold weather, hot, humid environment, physical activity, anything which stimulates your heart to beat faster and stronger can precipitate in the anginal person, can precipitate the anginal attack. Stress is a very common cause of the anginal attack. Now, what do? You position the patient comfortably. Comfortably is going to be upright. Basic life support need not be done because the victim is, doctor, I'm having an anginal attack. Remember, my airway's open, I'm breathing, and my heart's beating because I'm conscious. So you don't have to do airway breathing or circulation. If there is a history of angina, if they have a history of angina, then what you're going to do is give them nitroglycerin. They're going to take their nitroglycerin. They have it with them. Whether it's 1 pill, 2 pills, or 1 spray or 2 sprays. Many persons, the smarter ones, have what's called nitrolingual spray. It's better than the pills. They take it, and you give them oxygen. Remember, oxygen, because the reason the heart muscle, the reason they're having chest pain is their heart muscle is not getting enough oxygen. Oxygen will help. Nitroglycerin helps faster. Both of them are good. If they need more nitroglycerin, give it to them 5 minutes later. If the second dose doesn't work, you give a third dose 5 minutes later. Once the episode is over, it's done, period. Find out why it happened. Most often in dentistry, it's fear. Remember, some people faint. These people have chest pain. Now, if there is no history of angina, as I said before, if there is no history of angina, activate emergency medical services immediately. It might be angina, but it might not. So you call the ambulance service. Then you give them nitroglycerin and oxygen, the same exact thing you did for the patient we have a history of angina on. But the difference is when you are with a person who has never had chest pain before, call the ambulance. Call the emergency medical services. If after 3 doses of nitroglycerin they still have chest pain, you will make a presumptive diagnosis that it's not angina. Angina, by definition, when you give the anginal patient nitroglycerin, the chest pain goes away. That's the definition of angina. If 3 doses of nitroglycerin do not work, it ain't angina. You're assuming now it's a myocardial infarction. Again, no chest pain, chest pain with no prior history of angina, you think MI. You think myocardial infarction. This is what a myocardial infarction is. This is a coronary artery. This is plaque that forms inside the artery wall. What happens is blood is flowing.
Unstable angina and myocardial infarction are thought to occur when the fibrous cap ruptures, exposing the underlying cholesterol core to the bloodstream. The subsequent activation of clotting factors causes an acute thrombosis, which suddenly blocks most or all of the blood flow through that artery.
Okay, let me do that again for you. Okay, this is the plaque inside your coronary arteries. These are red blood cells and platelets. When this cholesterol-rich substance breaks through into the artery lumen, blood clots begin to form. Now, down here on the right-hand side of the screen, this muscle, which is pumping out blood, is no longer getting any blood. That muscle down there can no longer function normally. You ever go to sleep at night and you wake up in the morning and you've been lying on your arm all night and it's dead? Okay, well, you know, you can't use it, can you? It sort of it does weird things. That's what's happening. This coronary artery is occluded. Well, you know what? This is the left ventricle, folks. This is the part of your heart that does most of the work of your heart. And right now, we've turned off the blood supply. That muscle can't contract. Now, most of the heart is still working, so it's still pumping out blood, but it's pumping out less blood. Enough blood to keep that person conscious. In a myocardial infarction, the victim is still conscious, but they're living with less blood. So their level of consciousness has been altered. The patient is going to have certain signs and symptoms. Heaviness, tightness, a crushing sensation, a heaviness like there's a boulder on my chest. They don't use the word pain. They don't say knife-like, sharp, stabbing. No. Dull, aching, tightness, constricting, burning. It radiates. Upper epigastric region, the stomach. You feel like you've overeaten. The word is bloated. You feel like you have a lot of gas. A heaviness in their chest. Not in one spot, but all over. It radiates down the left arm. It radiates to the left neck and the left mandible. That's cardiac pain. The patient, nausea and vomiting. Conscious awareness of their heart beating. It's called palpitations. Shortness of breath. And quite honestly, the patient who's having a myocardial infarction does say to you, Doc, this is it. This is the big one. There's a sense of impending doom. They sense that something catastrophic is happening to them. Well, again, what you're going to do is you're assuming the patient is having a myocardial infarction, not angina, if they've never had it before. First time chest pain, you always think MI. If they have a history of angina and they say, doctor, call the paramedics. Just like the asthmatic. If the asthmatic says, call 911, call the ambulance, I'm going to call the ambulance. If the person with angina says, doc, this is it, the big one, I believe them. You call the ambulance. A patient who takes nitroglycerin and it doesn't relieve the pain, you simply call the ambulance. Okay? Position comfortably, give nitroglycerin. If the pain doesn't respond, you activate emergency medical services. We're going to give the victim aspirin. Remember, one of the drugs in the kit was aspirin? We're going to give him aspirin. One aspirin tablet, 325 milligrams, chewed, swallowed. You know why? The blood clot is only this big. Well, as time goes on, it gets bigger and bigger and bigger. Now, you know what? I don't want to have a heart attack. I don't want to have an MI. But you know what? If I do, I would like to survive it. I'd like to survive it with little to no permanent damage done to my heart. You know why? I'm an active person. I go running every morning. I like doing athletic things. If I survive my heart attack and my left ventricle is severely damaged, I could probably not even walk from here to the back of this room without having to stop 3 or 4 times because of shortness of breath. I don't want to do that. I don't want to be in a wheelchair sucking oxygen. Now, it's better than death, okay? But I don't want that. I want to be me. I want to enjoy myself. I want to go out and run. I want to do things. If I go to the hospital, if I'm having an MI, and if I get into the system, 911 in America, and I go to the hospital, they can do things to make that blood clot go away. They can inject drugs that dissolve blood clots. The fibrinolytic drugs, the blood clot dissolves. And that heart muscle of mine survives. They can do what's called a primary balloon angioplasty. Put a catheter to the femoral artery. The catheter goes into the obstructed coronary artery. There's a blood clot there. On that catheter is a balloon and a piece of metal called a stent. They put it into the obstructed artery. They inflate the balloon, which opens up the artery, opens up that piece of metal called a stent. They deflate the balloon and take it out, leaving the metal framework there, and that keeps the artery open. Now, they will do that in the United States if you get into the hospital within 6 hours after the occlusion occurs in the coronary artery. Now, you're sitting there saying, 6 hours? Wow, that's easy. 6 hours? Who the hell is going to wait 6 hours? Everybody. First-time heart attack victims in America. First-time heart attack victims. The average time from the onset of signs and symptoms until they get to the hospital is in excess of 7 hours. You know why? Very, very simple. Guys, there is not a gentleman in this room who really and truly believes that they will have a heart attack. Everybody in this room thinks that they are immune. Heart attacks happen to other people, to you, not to me. That's what you're thinking. So when it happens, and remember, you just ate a big meal, and you have a feeling of being bloated. Is it a heart attack? Did I overeat? Hell, I must have overeaten. It's just a little tingling in my left arm. I must have banged my arm. And you say, you know what, I'll be okay. I'll take my Pepto-Bismol, my Gelusil, my Mylanta for the indigestion. I'll go to sleep and I'll be okay in the morning. My dad, back in 1966, I was married at that time. He went to bed. Never woke up. He had indigestion. He had indigestion at night, and he went to bed, my mom, and he never woke up. Okay, that's what happens. It's called denial. Okay, it is not just a big river in Egypt. Denial is what kills you. Now, so you survive your first heart attack. You survive it. You took 5 hours to get in, but you know what? You got in. By the way, the reason they don't do it after 6 hours is the muscle's dead. Heart muscle is dead beyond repair in 6 hours. So if you are there 6 hours and 10 minutes later, they won't do it because there's nothing to do. You can't salvage dead muscle. Once you survive the first heart attack, if you have a second one, you're probably in the hospital within 10 seconds. And of course, you know the reason. You've been there and done that, right? You understand what's going on, okay? The president of my country, Dick Cheney, okay? The president of my country has had multiple heart attacks. You understand I'm not kidding, don't you? No, he's not vice president. He's not the vice. Give me a break. He's the vice president. Give me a break. No. He may have the title vice president. Never mind. I don't want to get into politics, okay? I feel safe doing that here. Okay, I wouldn't dare do that back in the United States. There are too many red states, not enough. I'm sorry. I shouldn't do that. I'm sorry. He's the president. What, do you think this other one is president? All right. They give aspirin. That's your aspirina. I got that off the internet this morning. You know what it does? By taking one aspirin tablet and chewing it, look at this, a 25% reduction in mortality from heart attacks. One aspirin tablet chewed, because once you break it down and swallow it, it's absorbed more rapidly. And you know what it does? It prevents the blood clot from getting any bigger. Now when you get into the hospital, they can get that catheter through better. One aspirin tablet. Monitor vital signs. Again, when the paramedics arrive on the scene, they're going to take over, they're going to stabilize the victim and transport them to the hospital. In a myocardial infarction, the most important thing, if you want to survive your MI, time is of the utmost. You've got to get into the system as fast as possible. That heart muscle's dying. Not just that you're going to live with a damaged heart. As muscle dies before it is dead, it becomes hyperexcitable. And that's the problem. This is a normal sinus rhythm. This is what your heart should be doing right now. This is what your heart is beating, the ventricles contract, you have what's called a QRS complex. This is systole. The heart is contracting and pumping out blood. The space between these two is called diastole. That's when the ventricles refill with blood. A normal sinus rhythm. This is good. This is what is happening to the person who is having a myocardial infarction. Their heart is beating normally. These are normal heartbeats, but every once in a while, you're going to see one of these weird-looking things, like right there. That is a premature beat of the ventricle, a PVC, a premature ventricular contraction. The part of the heart muscle that is damaged, that is dying, heart muscle that is dying becomes hyper. Now, when heart muscle gets hyper, it depolarizes prematurely. You know what happened? The heart contracted on the left-hand side of the screen. It pumped out blood. The heart refills with blood. The heart contracts again. It pumps out blood. The heart refills with blood. The heart contracts again and pumps out blood. Look at the distance between the irregular beat and the regular beat. It's a lot shorter, isn't it? The heart contracts and pumps out blood, and then as the heart begins to fill, but before the heart is filled, it contracts. There's not a lot of blood inside the heart. On a PVC, when the heart contracts prematurely, if you're taking the patient's pulse, there is none. There's no blood being pumped out. On the bottom, let's take the patient's pulse. Beat, 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 beat. Whoa. Every third heartbeat is missing, is what you're going to say. Every third heartbeat isn't there. No, it's there. You simply can't feel it because there's no blood being pumped out of the heart. That's what happens in a PVC. This is damaged myocardium. This person is conscious. This person has chest pain. This person is having a heart attack. Now, look what happens. When you die, you're sitting at home, you're ignoring this, you're still eating. When a person dies, when an acute myocardial infarction becomes cardiac arrest, it happens usually in the first hour after the onset of the obstruction. And that is always, always before the patient gets into the hospital. Most of the deaths occur at home. In fact, it has been written, it has been said, it has been proven that if you survive a heart attack, a myocardial infarction, if you survive to reach the hospital, you will survive to leave the hospital. Once you get there, the problem is over half of them never get there alive. They wait too long. The cause of death is cardiac arrest. Now, this is the important concept for you. Cardiac arrest doesn't mean the heart is not beating. The heart is beating. In fact, it is beating 220 times a minute on that video. 220 beats a minute. The heart's contracting like a fist, the way it's supposed to. 220 times a minute. But there's no blood being pumped out of that patient's heart. That's cardiac arrest. When there's no blood being pumped, you're in cardiac arrest. This heart is beating, this rhythm is called ventricular tachycardia. You know what? If you look at any one of those beats individually, any one of these beats, it's a PVC. Remember that one we showed you the last slide? Premature ventricular contraction every third or fourth beat. Every beat is a PVC. There's no blood in the heart. The heart contracts, there's nothing in there. 220 beats a minute is almost 4 beats a second. There's nothing. This is cardiac arrest. See, a lot of people believe that cardiac arrest means a flat line. Well, cardiac arrest is a flat line. But it's also this. By the way, flat line, asystole, bad. This, good. Now, it's kind of weird to call cardiac arrest good, isn't it? But if you have this rhythm and you're in cardiac arrest, and if I have a device called the defibrillator, you are going to live. You know why? That muscle's alive. This muscle is alive. Now, this muscle is beating in an organized manner almost 4 times a second. But the heart muscle itself is not getting any fuel. It's using it up. As it uses it up, the muscle, well, that's what happens. It's going in the wrong direction, but that rhythm is called ventricular fibrillation. VF, What the difference is between the last one and this one, in ventricular tachycardia, the muscle's working in an organized manner. What's happening here is as the muscle begins to die, the beating of the heart becomes totally unorganized, chaotic. And we call this coarse ventricular fibrillation. Okay? Here's what it looks like. The first couple of beats you're going to see are normal. This heart is beating perfectly normally the first 2 or 3 beats. Then you'll see ventricular fibrillation. Normal heartbeat right there. This is ventricular fibrillation. You understand the squiggly lines now? Okay? It's cardiac arrest. There's no blood being pumped out. This is not as good as V-tach. See, look, cardiac arrest is bad. You understand that's bad. But when you have some kind of a rhythm going, that's pretty good. That rhythm degenerates into ventricular fibrillation. And that rhythm degenerates into a flat line. And when you have a flat line, you're dead. You're dead forever, by the way. See, ventricular fibrillation is, you can still live. If we defibrillate you, if we shock your heart and it beats again normally, you could survive. If you have a patient who has a flat line, the muscle's dead. You can go into a meat market and buy a piece of steak. And you can defibrillate it as much as you want. It isn't going to work. You cannot make dead tissue alive again. You simply can't do it. So what we're dealing with again is time. Time. The longer it takes to start the heart, the more damage there is to the heart, and the lower your chance of survival. I gave you that number earlier today in the United States. 95% of out-of-hospital cardiac arrest victims die. 19 out of 20 die. I've never won the California lottery. I'm not going to be the one person who survives cardiac arrest. I want to survive it. Well, there's one reason why I might not. Gee, we went to lunch today. We almost didn't get back here because of traffic. Welcome to the world, folks, right? Everybody got to have a car. And you're sitting, if you're waiting in your house or your dental office for that ambulance, that patient is in a lot of trouble. That ambulance ain't going anywhere. In New York City, in Chicago, in Los Angeles, the survival, remember, nationwide survival rate is 5%. New York City, Chicago, Los Angeles. 1% survive. Why? Traffic. I live in Los Angeles. All right, so we're in the dental office. The patient is sitting in the dental chair. The patient is having chest pain. You activate emergency medical services. The ambulance will be there as soon as they be there. The patient is sitting in a chair upright, comfortably. You're giving the patient oxygen. You've given them an aspirin to chew and swallow. And what else can you do? Pray. Pray that they stay alive. As long as they're conscious, remember, as long as they're conscious, it means the pump is still working. Now, the patient, shake and shout. No response. Position supine. Head tilt, chin lift. Look, listen, and feel. He's not breathing. 2 complete full ventilations. Check his pulse. It ain't going to be there. And now you start doing your 30 compressions and your 2 ventilations. Question, can you do effective chest compression with the victim in the dental chair? And the answer is absolutely, positively yes. You may take a CPR class somewhere along the line where an instructor says to you, the instructor, by the way, is not going to be a dentist. There'll be a physician, a nurse, a layperson, maybe even a physician. And they're going to say to you, and it's true, in order to circulate blood in cardiac arrest, the victim must be on a hard surface. And that is true. If they're lying on a mattress, you place them on the floor. You want them on a hard surface. A dental chair, Anthony Lepere is a dentist anesthesiologist in Perth, Australia. He did a study with his dental students at the University of Western Australia, and they proved, I don't know how he got volunteers to sit in the dental chair and have CPR done. It was easy. Do you want to graduate? Get in that chair. Now in America, we can't do that anymore because now the student says to me, I'm going to sue. Remember 100,000 attorneys? We can't do that anymore. In the old days, it was easy. Dr. Gowgates came to my school to demonstrate his technique. I needed volunteers. Hey, you, get in the chair. Yes, sir. Not anymore. You can do it. You leave the person in the dental chair. You can effectively circulate blood with the victim in the dental chair. Ice hockey is probably one of the sports you don't even care about here. Detroit, Michigan, the Detroit Red Wings. Hockey Town, USA. They love the Red Wings, name of the team. On November 22nd, during a game, this is the Detroit Red Wings, 22,000 people in the stands. There's the coach of the team. There's a 24-year-old player in cardiac arrest. He came off the ice, collapsed, and was in cardiac arrest right there. This person right now is doing chest compressions. Out of sight where you can't see him is another man who defibrillated him. And 15 minutes later, he was in the hospital wanting to go back and play. They did let him. In fact, they actually canceled the game, which is amazing. He was in the right place at the right time when he had a cardiac arrest. If he had been anywhere, if he had been at home, he would be dead. He was dead. He was technically dead. He had no pulse, he was not breathing, and he was unconscious. They brought him back to life because he was in the right place when he had his cardiac arrest. The device they used was an automated external defibrillator, the AED I mentioned earlier this afternoon. Here's what happens if a patient, a person, has cardiac arrest. And as I mentioned to you earlier, you activate the ambulance and you pray, or you cry, or you do nothing. Ventricular fibrillation becomes a flat line. The ambulance arrives, and I don't care what they do. They arrive, by the way, 10 minutes later, you're dead. You're dead. That muscle is beyond repair. And by the way, if you by some miracle do survive, your brain's damaged. You know why your brain's damaged? Because the brain dies faster than the heart. The brain, neurons in the brain have a higher metabolic rate. They use up oxygen faster than the heart. Brain cells die. Within 3 minutes of a lack of oxygen, you have permanent brain damage. The heart muscle's alive for a lot longer. Do you want to survive a cardiac arrest? I don't know if you know her name here down in Guatemala, but this happened in Florida, and we had a big thing last year in America with a lady named Terry Schiavo. Terry Schiavo was that 28-year-old lady in Florida who 15 years ago had a cardiac arrest. She's 28 years old, and she survived her cardiac arrest. She survived it. Her heart was 28 years old. Her brain was dead. She was in a permanent vegetative state for 15 years. And then the reason you heard about her was because we couldn't let her die. It became a Congress thing to keep her alive. I don't want to have that. I don't want to live like that's not living. Okay? You don't want this to happen. Doing nothing means you're dead forever. So let's do something. Let's do CPR. Let's circulate blood which contains oxygen to the heart and to the brain. Doing CPR is not going to make the heart beat normally again. It will not do that. What it does do is it keeps the muscle doing something by circulating blood which contains oxygen. When the paramedics arrive on the scene, 10 minutes later, they don't find a flat line. They find something. Any heart activity is better than a flat line. They will shock. It may not work. They'll give drugs, epinephrine. They'll shock again. Doesn't work, more epi. Shock again. Survival rates of around 5%. This is the typical United States scenario right now. CPR is started somewhere along the line. The paramedics arrive 10 minutes later. They find some minimal activity in the heart, 5% survival, probably with some small degree of brain damage. In other words, not Terry Schiavo, but you won't be you. You'll be different. And I've met a couple of people in this room where that could be an improvement. Now, let's get even smarter. We're going to start doing CPR, and we call 911. You call the ambulance service, and they arrive in your office not 10 minutes later, but 7. Look at the difference. 7 minutes later, you don't have a flat line. You don't have a barely alive heart. The heart muscle is still very, very active. It's in ventricular fibrillation, but it's more alive. If the muscle is more alive, it responds better to the shock. And survival rates here are about 20% with no brain damage. Time factor. Let's get even better. Dr. Malamud has bought an AED. And I am with you when a cardiac arrest occurs. We start doing CPR, and we are able to shock you within 4 minutes. Survival rates as high as 74% have occurred. No brain damage at all. Look at the difference here. If you do nothing, you're dead forever. Now, the difference in 5%, 20%, and 74% is when we shock the patient. That's the only difference. The faster you shock the patient, the more likely they are to survive the cardiac arrest. I'm not going to go into this slide at all, so let me just get rid of this one. I have a video of the first use of a defibrillator. Now, you know what a defibrillator is? It shocks the patient. You're delivering an electric shock across the patient's chest. We have sophisticated devices right now. The first physician, Dr. Zoll, the first person to ever shock a patient in the 1950s, there's a company, the Zoll company, that makes a defibrillator. It was Dr. Paul Zoll. And he used electric current out of the wall. We don't do that anymore. We've sort of made it more sophisticated. But I happen to have a video that shows this. Now, what this video is, I use this video in 2 classes, emergency medicine right now, and in my class on sedation. You're going to see a patient who is 3 years old, who is very uncooperative. He needs sedation. So the person is going to give that patient, they're going to put the medication into some food to sneak it in. Oral medications work in about a half an hour, more or less. The problem with oral sedation is you can't control the way the drug works. And what you're going to see here is good sedation becoming an overdose, requiring resuscitation. The nice part about this is the outcome is successful. So let's look at this video.
Ball likes you when it rubs belly.
That is amazing. He doesn't like anybody. He never usually likes guys.
He doesn't like bad guys.
Is that right?
He can tell that you're an animal nut. You are, aren't you?
You got me pegged. You know, in Nepal, the villagers there called me Kintanti, which means noble man who is loved by many animal, who in kind he loveth too.
Would you like a cup of tea or something?
I'd love a brewski if you got one.
We can do that. Hey, Magda, why don't you help me in the kitchen?
Oh yeah, certainly, of course. Kintanti.
Puffer doesn't like bad guys, does he? Puffer. Puffer. Puffer, come on, boy.
Would you like a little clam dip, doll?
No, thank you. I'd love a bundt cake if you have one.
Bun cake?
1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3.
It's hot
Budweiser or a Heine?
Whatever. Stay away from the light.
Okay, I'll just get you a regular.
There it is. It worked. Something About Mary is the movie. I mentioned earlier that there are new guidelines, and I have my website, and if anybody wants to go up to my website, you can download this. And it's basically, it's in the section called Downloads on my website, and you simply download the document for new CPR guidelines. And you can print it out or you can keep it on your computer. Let's go back to the first thing I showed you this afternoon. Remember that man we didn't do it right? We're going to do it again.
You okay?
It's a little hot in here.
Well, it seems okay, but we'll check. I think it's a little hot in here. You mind checking the air conditioner? Go check that.
Sure you're okay, Charlie?
I have some bad indigestion.
Charlie? You okay? Let's go get some oxygen. Charlie? Charlie? He doesn't have a pulse. Call 911. We have a cardiac arrest.
The dentist noticed none. The dentist tells the assistant to activate emergency medical services. We have a cardiac arrest.
Go get the AED.
Medical emergency, please.
The AED is placed by the victim's left shoulder and turned on. At this point, CPR is discontinued, and you follow the instructions from the AED.
Remove all clothing from the patient's chest. Take out adhesive pads. Press electrodes firmly onto the patient's bare skin. Analyzing rhythm. Don't touch the patient. Shock advised. Charging. Charged. Stand back. Analyzing rhythm. Shock advised. Charging. Charged. Stand back. Analyzing rhythm. No shock advised. Check airway. Check breathing. Check pulse. If no pulse present, administer CPR.
It's a pulse. We're doing a filling on this gentleman, and he became unresponsive, and we hooked him up to the defibrillator here, and he was VFib, and we shocked him, and he got a pulse back.
Okay. Sir, are you awake? What kind of history do you have? Have you ever had trouble like this before?
No.
Never had any chest pain or anything? Did it come on all of a sudden? coming also, so they'll be coming along behind us here. See if we can get an ID started before they get here.
Hey guys, we're back here.
Oh, good. Hello.
Right after immediately? Okay.
Well, yeah.
Any chest compressions or anything?
Yeah, after a little while. Hang in there, Charlie. We're going to take good care of you.
Okay, again, my email address, in case anybody has any compelling, urgent need to contact me, is stanley@drmalamed.com, and my website again is drmalamed.com. And this is what you'll see if you go to the website, and this is where you want to go. The download, just click on the downloads, and you can download. I have a number of different documents there. One of them is the new CPR guidelines. And with that, yeah, there he is. This is me when I first got. This is when. Oh, he's not here. Is he here? Where are you here? He left. Okay. This is when I knew Dr. Zacharison, when he had a beard and hair like that too. At that time. Thank you, folks, very, very much. Thank you. And one last thing. I want to congratulate this man. Don't go away yet. I've been at USC for 33 years, and I've gone through 8 deans. 8 deans in 33 years. To get a man who's been the dean of a school for 25 years, come on. Fantastic. You've done well. Thank you very much. Thank you. And congratulations. Thank you.
Thank you very much.
Good. Enjoy the rest of your meeting. Thank you.
Thank you very much, Dr. Malamed, for this wonderful lecture. And this story of being a dean for 25 years, I don't know. Dr. Ayao, who was the president of the university, a founder of the university, said, well, I hope that you are ready to go for another 25 years, and then I want to give the speech. So I don't know how much more time we're going to be around here, but the thing is that we're doing our work with enthusiasm, and many things has to be done yet in our dental school. But for us here, it was an honor to have you here in Guatemala. I heard you lecture several times in the United States, and always we have to learn many, many things from you. And we're keeping your book. I'm one of the teachers or professors of local anesthesia in Guatemala in our dental school, as I was at University of San Carlos also for many years ago. And believe me, your book is an excellent guide. There are some different approaches, as you said, in certain anesthetic techniques, but that is natural. But I think that many, many things that you said are what we follow here. And I would like to present you with this little certificate of appreciation that says University Francisco Marroquín presents this certificate to Dr. Stanley Malamed for his wonderful collaboration in the lectures, the techniques of local anesthetic that was given this morning, and medical emergencies in the dental clinic. During our celebrations of our silver celebrations, 25 years of foundation of our dental school. Guatemala de la Asunción, that's the name of our city, April 26, 2006. It's signed by Ingeniero Giancarlo Ibarwen, who is the president of the university, and myself. Dr. Malamed.
Thank you very, very much.
Thank you very much.
Thank you.
Thank you very much. so you can keep it.
Okay, thank you. Thank you.